Okay, it's eight
Ready?
o'clock. We'll go ahead and get started. I'll introduce myself. My name is Christy Stewart. I'm the Physician Relations Coordinator for the Medical Society of Delaware. I want to welcome you all here today for a great session. This is our 2026 Insurance Payer Workshop for our Practice Management and Leadership Education series. Uh, we have the agenda here below. We ask that everybody please mute your mics. If you do have any questions throughout each presentation today, we ask that you put those questions in the chat box. If you have any questions regarding reimbursements or claims, we ask that we take those questions offline and the representatives will go ahead and answer those questions separately, privately. Again, if you do have any questions, feel free to put them in the chat box. Okay, we'll go ahead and we'll get started. Our first presentation is from Highmark Health Options. Thank you so much for joining us today, Desiree Charisse. She is the provider account liaison for Health Options, and I would like to welcome her here today. Desiree, you there?
Yep, sorry. Thank you.
Okay,
I was
scared me for a
talking
second.
on mute. Am I sharing my screen or are you?
We see you, but your screen is not shared.
No, okay. I didn't know if we were or you
Mhm.
were with the ones we sent over. That's all. All right. Are you able to see it now?
Yes, ma'am.
All right. Good morning. As Christy mentioned, my name is Desiree. I am one of the provider account liaisons here at Highmark Health Options, and I'm going to go over our presentation. I did get some information a little bit late, which is our membership numbers. So I just want to go over those. Right now, our current membership total is 113,646 members. By county, we have Kent County has 21,533 members. Newcastle County has 65,605 members, and Sussex County has 26,508 members. So starting today, our agenda is we're going to go over some provider tools that are
As far as I
available.
know, I've not heard from anybody.
Helpful provider information, and then some updates on our dual eligible special needs plan or DSNP plan that came in, some changes that came effective 1/1 of 2026. So provider tools that we have available to you. Our provider portal still is Navinet. We get asked that often. So Navinet is our provider portal. There was a change in the instance that you see. Now you will see the one that is highlighted with the stars and in red. That's the Highmark Health Options Delaware Medicaid and DSNP plan. This is where you can do all of your claims information, your claims search, appeals and disputes can be done here. We do have a secure messaging system. If you have a question on a claim, you can submit claims here. Both UB and 1500 claim submission can occur here. And this is also where you're going to see where you can get your authorizations, where that guiding care is. We also have a prior authorization code lookup tool, or PAL. This should be utilized before all services to see if a prior authorization is needed. We did just recently update our prior authorization, so make sure you are checking this at the time of services. And then if it does tell you, or if it does need an authorization and it is through a vendor, when you do that search, it will tell you where to get that authorization from, which vendor it would be through. PNC Echo is where your remittances will be coming from currently. You can use that. If you've already used it in the past, you might be familiar with it. If not, we do have a user guide out on our website. And it did transition about a year ago now, 3/1/2025. So you should be getting them. If you hadn't already, you can sign up for EFT through PNC Echo. But the default method is a virtual credit card. So if you've been receiving payments, it would be on there if you hadn't signed up for the EFT. But you also can get an e-check or a paper check if you prefer that way. Again, if you already set up with PNC for another Highmark line of business, it's a very quick and simple change just to update the modality choice for Highmark Health Options. But if you would like to switch to EFT, you can log in using your TIN and the recent draft number of a payment. And again, these links are clickable. So I believe, Christy, you're going to be sending this out, correct? If
Yes, yes.
if not, it's also on the Highmark Health Options website. But all of these links are clickable to get to where the enrollment guide and user guide both are. Some helpful provider information that we see that have come across. Our mailing address changed again about a year ago. It is Highmark Health Options, Post Office Box 21771 in Eagan, Minnesota 55121. All paper claims must be mailed to this address regardless of data service. And all members will receive an ID card. We did change that prefix. It's now HXL for Medicaid members. And that is the prefix as of 3/1/2025. If it's prior to 3/1/2025, you would use the old prefix. Balance billing. Members cannot be balance billed for any reason. If you have any questions about balance billing, this is in our provider manual as well as it is part of contracts. So just review that information. If you have an issue where you are needing assistance in getting COB information from a patient, you can call our member services line. They are able to help you get that resolved, but you cannot balance bill the member. 21st Century Cures Act, as we all are familiar with, we are coming into compliance with the 21st Century Cures Act. It's a CMS requirement that the state of Delaware is in compliance with as well. And they use a vendor called Gainwell Technologies to do that service. You must register with Gainwell, and that is a combination of your taxonomy and billing or service address, as well as your NPI. And each group is specific to the service address. The practitioner level is just the NPI and taxonomy. Proactive measures for you as providers is to make sure that you have an active registration. There is a revalidation date, and if that is not done, then the provider will terminate. So please make sure you're going in to the Gainwell portal regularly to check your notifications. They do send those out for that. Make sure you are billing a consistent taxonomy. We need the taxonomy that is registered with Gainwell that to be put on the claim. So it has to be billed exactly as it is registered with Gainwell. And then we also need you to have the rendering and attending provider taxonomy. We have a temporary pause on this, but we are getting ready to turn that requirement back on. So when you are billing for your claims, make sure that your rendering and or attending is on the claim and that taxonomy that you have registered with Gainwell is what is included on your claim to Highmark Health Options. So the denials that you'll see for 21st Century, if you get it via Navinet, it's going to be an E1344 or a 270 denial on the claim line. If you get it on your paper remittances, it will be a COB7. So those are the two denials that you will see for, and that indicates that it is a 21st Century Cures Act denial and that you need to review the data that was submitted on the claim. Once you determine what was submitted incorrectly on the claim, then you would need to submit a corrected claim for those. You would use the frequency code of 7 on it to indicate a corrected claim, and you must include the original claim number. So make sure that you have everything exactly as it is registered in Gainwell. And then if you still have additional questions, we also have a tip sheet on this, and that is a clickable link there, but it is also on our website. Some billing tips that we're seeing that are coming in. As a reminder, our timely filing guidelines, our primary initial claims are from 120 days from the date of service that you provide. Primary corrected claims are 180 days from the HHO initial remit. Secondary initial claims are 60 days from the date of the remit of your primary payer. And then the secondary corrected claims are also 60 days from the remit of the primary payer. Again, going back to 21st Century, we're getting a lot of denials in that field. So please make sure that you are billing information based on what is registered and compliant with DMMA. And then prior authorizations, we went over that prior authorization tool. We're getting a lot of denials for no auth needed or no auth when there is an auth needed. So please utilize that prior authorization lookup tool to determine if an authorization is needed for all services. And then credentialing. Also ensure your provided data is correct and current for both your practitioners and your group with HHO. And lastly, you cannot date span claims. So claims cannot be billed over multiple months or years, with the exception of our inpatient claims. So we have our next is our dual eligible special needs or DSNP market plan changes. So the categorization of HHO duals eligible. There are 3 different types of eligibility for the duals members. Your first one is your full benefit dual eligible, and it kind of is explanatory on that they're eligible for Medicaid either categorically or through optional coverage groups, such as medical need or special income levels, for institutionalized or home and community-based waivers. It helps pay for Medicare cost sharing, and based on the state may pay Medicare Part B premiums. There's a qualified Medicare beneficiaries plus, which it helps pay for the Medicare Part A and B premiums and other cost sharing like their deductibles, coinsurance, and copays. The QMBs or QMBs may also have full Medicaid benefits. Specified low-income Medicare beneficiaries plus, they help pay for their Part B premiums and they provide full Medicaid benefits. There's some partials. So again, the qualified Medicare or QMB helps pay for Medicare Part A and Part B premiums and other cost sharing, but QMBs do not have full Medicaid benefits. There's the special low-income Medicare beneficiaries only. They help pay for their Part B premiums, and they again do not have full Medicaid benefits. Then the qualifying individual help pay for Part B premiums, and they again do not have full Medicaid benefits. Beneficiaries who fall into these categories, again, do not have those full Medicaid benefits. They are eligible to enroll in the Highmark Health Options Dual Select Plans, though, in 2026. So we have an integrated claim submission process for the Highmark Health Options Duals aligned members, and aligned means that they are getting both Medicaid and Medicare DSNP plan from Highmark Health Options. So effective January 1st, 2026. So this is for dates of service 1/1/26 forward only. Providers are now required to submit one claim to the Highmark Health Options Duals Medicare Payer ID, which is 47183, for your aligned members. Highmark Health Options Duals Plan will then process the claim under both the HHO Duals Medicare and Medicaid benefits, eliminating the need for the providers to submit 2 separate claims. Again, for institutional, this applies to claims with an admit date of 1/1/26 forward. Claims with a admit date prior to that, you would follow the existing process of submitting to the duals and then to Medicaid. And for outpatient, this would be for all dates of service are that 1/1/26 beyond. Coding and submission requirements. So if a claim is submitted to Medicaid first for an aligned HHO dual members, it will be denied. It does have to go into the duals plan first. And when you are submitting the claim, please make sure that all relevant Medicare and Medicaid codes should be submitted on the initial claim submitted to the HHO duals plan. If different codes are used for Medicare versus Medicaid, the claim must include all relevant codes on the single claim submission. So as an example, if you have a member that is an LTSS or home-based service that are typically submitted to Medicaid only, you would need to submit that on the Medicare claim as well. For rejected or corrected claims for this submission process, if a claim is submitted with an invalid member ID or a Highmark Health Options is unable to locate the member based on the information billed on the claim will be rejected for HHO duals. You will receive a rejection from that for the HHO duals Medicare only, as we have not adjudicated it over to the HHO Medicaid yet. You will then need to submit a corrected claim to the HHO duals Medicare Payer ID with the correct member information. With that, if a corrected claim is submitted to the HHO Duals Medicare Payer ID, then Highmark Health Options will automatically review the claims corrections for impacts to both HHO Medicaid and HHO Medicare. If a corrected claim, though, is submitted to the HHO Medicaid Payer ID, the provider, then the correction will only apply to the HHO Medicaid claim. There will be no change in the way you check your claim status. You can do that again via Navinet. They should continue to use, or providers should continue to use your members' HHO Duals Medicare or your HHO's dual or Medicaid ID to check the status of your specific claims within the system. And you will receive two separate payments or 835 transactions, one for your HHO Duals Medicare and one for the HHO Medicaid claim. Members, though, will not receive an explanation of benefits. However, the member will get a coverage decision letter if a claim is denied partially denied under both the HHO Duals and the HHO Medicaid plans. So provider services should always be your first point of contact with us. They are available, more readily available 8 to 5, and they have a lot of the same system of access and even more than we do. So we do ask that you reach out to them first. But if you are not able to get an answer from them, they will refer you to your provider account liaison. So on the next slide, we do have who our provider account liaisons are and what areas they service. So if you are not familiar with your provider account liaison and who that may be, we ask that you please look at this slide, and I'll leave it up for a minute and write down who your contact might be. I can go over them really quickly. I handle all of the hospital HCs and higher level providers. Jerica is our DCSN, handles our chiropractors, pain management, and behavioral health for all counties. Christina Hales, if you are a PCP specialist or an LTSS provider in Newcastle County, that's going to be your provider account liaison. Sarah Pearson is your provider account liaison for Kent County for PCPs, specialists, and LTSS. Rebecca Miklos is for DME, minor home modifications and lab for the entire state. Lisa Maselli is our home health, private duty nursing, therapies, hospice, or pediatric skilled nursing facility for the entire state. And Noah is our radiology, home infusion, ambulance, dialysis, rehab hospitals, LTAC hospitals, ambulatory surgery centers, and urgent cares for the entire state. So again, if you are not familiar with who your rep is, please write that down, but our provider services should be your first point of contact. So that is the end of our slides, Christy. I don't know if we have any questions or...
We do have a question that came through. The question is for patients who do not have full Medicaid benefits, can those patients be balance billed? I'm assuming maybe she's referring to patients who only have, for example, family planning, like just a pregnancy visit, just as an example. I'm not sure if that's what she's referring to.
Yeah, so I think it's about the DSNP members, and we do have a provider manual that goes over that. I will put that link in the chat because there is a provider manual that is specific to DSNP and what those regulations are, because they are a little bit different than Medicaid.
She says the SLIM, SLIMB.
The Flimbees, yeah. So again, that's part of the DSNP, and I'll put that in there because we do have a full provider manual which goes over that because it is different than Medicaid, yes.
And if I can just add, I apologize. It's Paula Victoria. I'm the manager of provider relations for Highmark Health Options. The program that she's referring to, although it's a partial for DSNP, these members do have their full Medicaid benefits, so they would not be able to balance bill those members.
Okay. Okay, thank you so much. Are there any additional questions that anybody has? Okay, I don't see any additional questions. I do want to thank you guys for a great presentation. Thank you for joining us today. Oh, we do have one. If we can't balance bill, is that all right? Do we have to write it off? Is that a write-off?
I mean, yeah, that would be an office position on what you do. You just cannot bill the member. That's payment by Health Options is considered payment in full for covered services.
And then an additional question came in. Does that mean no one pays the balance? Which I think you just pretty much answered the question that
Correct, right.
it would be considered paid in Health Options terms.
Correct. And that again is in our provider manual. I'll put both links to both the DSNP provider manual and the HHO provider manual, but it is also in the contract as well that members cannot balance bill
Okay.
after payment from Highmark. Even if we don't pay, even if Highmark Health Options doesn't pay and we deny the claim, you cannot balance bill the member. You have to work with us to get that payment made due to whatever the denial is. And again, sometimes it comes across as a COB denial because they say they have primary. We have member services that help you work through that with the members to get that information so you can get primary payment and then payment from us.
Okay, great. Thank you so much.
Uh-huh.
Okay, again, I want to thank you guys for a great presentation. Thank you for joining us today. We really appreciate it. If anybody does have any questions that may pop in throughout the day, feel free to shoot me an email and I'll do my best to make sure that we get those questions answered. I will be sharing again these presentations as long as they are approved by each payer. Those ones will be sent out sometime after today's meeting.
Okay, and I'll stay on for a couple minutes just in case anything comes in through the chat for see and monitor there.
Oh, thank you so much. I really appreciate it. Okay, our next presenter today is going to be from Aetna. This is Cloris Waters. She is the Director of Network Relations for Aetna. Cloris, are you there?
Hi, Christy. It's actually Kristen. Can you hear me?
Oh, Kristen, you're here. Yes, I do hear you.
Cloris is here as well, but I just wanted to make sure you guys can. And I'm going to share my screen.
Okay.
I just want to make sure. Let me know when you guys can see that.
Okay, yes.
Okay. All right. Is it okay to start? Everyone can hear me?
Yes, but we don't see your presentation yet.
Okay, hold on 1 second. If I go to share.
Here we go. It's starting to load in. There we go.
Okay. All right. Sorry, can you see that clear? Okay. All right. And you can hear me now?
Yes.
Too? Okay.
Yes.
Hi, thank you. And welcome to the 2026 Medical Society of Delaware Payer Workshop. I'm Kristen Cole. I'm the Network Relations Manager. I also have with me Cloris Waters. She's the Senior Analysis Network Relations, and we'll both be presenting today. Our agenda today is network management, healthcare professionals website, Aetna provider portal, reference tools, claims, network updates, resources, and questions. Our Delaware network management team consists of Andrew Richard, he's the VP and regional network lead. Mike Fuller, he's the chief network and operations. Laura Noor is our VP of network management. We have a contracting team, that's Kathy Cleese, lead director, and Deanna Santiago is the senior manager network management. The servicing team is our manager, Krista Herbine, myself, and Cloris. We're going to start with the healthcare professionals website. Working with us, our provider site. Whether you are looking to join our network, update your TIN, or find out if a procedure needs pre-cert, all of these things can be done using our Aetna.com website. Our website is easy to navigate and has all the information that you need. To start, once you go to Aetna.com, click on the I'm looking for drop down and select providers. This takes you directly to our provider site. Right there is also the Aetna.com/healthcare professionals. It's right there. Here you will see a banner that has the most common topics that a provider would be looking for. Below is a screenshot of the topics that they have pre-cert. And then we have Aetna providers. There's different things, the availability portal, update provider information, find a provider. And there's also patient care and quality and to join our network or some of the things you can do there. To join our network, welcome to the Provider Onboarding Center. To join our network, we are excited that you're interested in joining our quality network of physicians and healthcare professionals. That's where you would start there, and then you can do different things as well. Here, complete a request. Here you can access and continue a saved request for participation, and you can stay up to date. Existing participating providers can update their demographic information. How to speed up the credentialing process. We hear you. We want you to know that Aetna is committed in reviewing your feedback and providing information to make it easier to work with us. Recently, some of you asked about getting added more quickly to the network. What to do before requesting to join the network. Please make sure the following information is up to date and cancel for affordable quality health care to ensure timely completion of credentialing. CAQH ProView application is a reattestation or initial application complete status. Make sure Aetna is listed as the authorized health plan. That CAQH ProView includes current provider professional liability insurance and policy information. CAQH ProView has all active service locations listed for that state for which the practitioner is requesting participation. And lastly, CAQH ProView includes an active current DEA and active current state license for every state in which the practitioner has active service locations. Stay up to date here for our resources. You can access Availity. Availity is our sole provider portal. Log in and sign up to get access to our newest tools and resources. You can update your tax ID. You can use a form there to update that information. Update your provided data. Update your provided data such as service location, phone number, telehealth services, email, and more. Or you can terminate your contract. Use this form if you are changing participation, relocating to a new state, or retiring or a provider is deceased. Help your practice by providing more detailed demographic information. Good health starts with good provider-patient relationships. Our members are diverse, so when they have the option to connect with providers who share their identity, they may feel more comfortable talking about their health. According to the Journal of American Medical Association, health disparities and inequities are linked to a lack of racial and ethnic similarities or shared identity between providers and patients. For this reason, we encourage all providers to self-identify. Updating is easy. The Provided Data Management tool on Availity allows you to update information about your business and providers. Keeping your information current and accurate by verifying it every month helps our members connect with you for care. Making updates in the PDM tool allows you to share information with Aetna and other payers, reducing phone calls to your office. Some other benefits include staying listed in the provider directory and avoiding potential claims payment delay. Updating your information is easy. Simply log into our Availity portal and navigate to My Providers and then to the Provided Data Management. If you need to add new providers to your practice, please use Aetna.com. Our resources. Here we have clinical policy, forms, Medicare resources, patients' mental health, education, training, and manuals, and regulations. Pre-cert information. Pre-cert applies to all benefit plans that include a pre-cert requirement. Participating providers are required to pursue pre-cert for procedures and services on the list below. And you can access them through Availity and different sites of ours, and you can go and check what's on there if you need to. For Aetna commercial plans, there is no pre-cert required for buprenorphine products to treat opioid addiction. Note, if we need to review applicable medical records, we may assign a tracking number to your pre-cert request. The tracking number does not indicate approval. You will be notified when a coverage decision is made. Louisiana providers, I won't go through that right now. Here on the pre-cert, you can search by CPT code, and you can look up codes to see if they may need the pre-cert or not. Our clinical policy bulletins. They explain the medical, dental, and pharmacy services we may or may not cover. They are based on objective, credible sources such as the scientific literature guidelines consensus, statements, and expert opinions. Here you can pull our medical, dental, and pharmacy clinical policy bulletins. You can also pull our FAQs and our clinical policy bulletin state deviations. Aetna Provider Portal. I'm sure everyone's familiar with Availity. We offer webinars here, Aetna.com webinars, setting up your account and finding help and training, Aetna eligibility and benefits, using claims management, working with Aetna on Availity, Aetna pre-cert and follow-up on Availity. We do monthly interactive webinars. Doing business with Aetna, you would go to, and it's the second Tuesday and third Wednesday of every month. Different things you can learn on here would be the claim tool, submission, status inquiry, and payment and coding policies, eligibility and benefits, EFT and ERA, online explanation of benefits, payment estimator, pre-cert, referrals, reconsiderations, and appeals can all be done. We have other Aetnas that do our other webinars. The Doing Business with Aetna webinar is available for new and existing providers and their staff. We'll show participants how to locate provider manuals, CPBs, and payment policies, access Availity and register for live instructional webinars, access our online forms, provider education bulletin, and our office links, navigate to our provider referral directory and Medicare directory, and update their provided data, and much more. That's the second Tuesday and third Wednesday of every month from 1 to 2:15. Working with Aetna on Availity. Get a supersized overview of how to use the Availity portal and how to work with us, plus trainer tips and tricks to navigate your way. That's the first Tuesday of every month from 2 to 3:30. Learn how to submit drug prior authorizations requests using Novalogics. Learn how to access Novalogics through the Availity provider portal to submit a specialty drug prior auth. Initiate a National Comprehensive Cancer Network regimen, and check the status of request. That's the second Thursday of every month from 1 to 2 p.m. How do you sign up? If you go on our website under resources, that fourth selection down is education, training, and manuals. Reference tools. Provider manuals about our policies and programs. Here you can view or download our manuals, the office manual for healthcare professionals, behavioral health and provider manual, EAP manual, women's health programs, and Aetna benefits and product guide. I am now going to turn this over to Cloris, and she's going to continue our presentation. Thank you.
Good morning, everybody.
Cloris, you can just tell me next.
Can you hear me? Can everybody hear me?
Yes.
Okay. All right. Good morning, everybody. I'm going to take it from here. I'm Cloris Waters. I'm the senior provider rep for the whole entire state of Delaware. And I'm going to start here with claims. Kristen, you can go to the next slide. Claims payment and reimbursement, convenient tools and guides to help you get paid faster.
Excuse me,
Tools
Cloris. This is Lynn
Yes.
Robinson. My apologies for the interruption. You have a little back feed going. I didn't know if there's anything that you can do to adjust that.
Okay. No, how do I adjust it? I'm sorry.
Actually, it just stopped now. So
I don't know what the back feed is. I'm sorry.
there you go. It seems to have stopped. Thank you.
Yeah. Okay. I'm sorry. Tools that save you time and money. We have ERAs and EFTs and electronic EOBs. Can you hear me? I'm sorry. Someone's talking. Okay. Coordination of benefits and payments and now I can't see it. Refunded overpayments schedules. Next slide, Kristen. Electronic transaction tools, digital member ID cards, Aetna signature administrators, and out-of-network benefits. Next slide, Kristen. I can't see the smaller writing. Our appeals and disputes process. Healthcare providers can use the Aetna disputes and appeals process if they do not agree with the claims or utilization review decision. The process includes peer-to-peer review. Aetna offers providers an opportunity to present additional information and discuss their cases with a peer-to-peer reviewer. As a part of the authorization of the utilization review, coverage determines process. The timing of the review is prior to the NNPO and incorporated state, federal CMS, and NCQA requirements. Reconsiderations, formal reviews of claims, reimbursements, or coding decisions or claims that require processing. Appeal requests to change a reconsideration decision, an initial utilization review, decision on an initial claim, decision based on medical necessity or experiments, investigational coverages. Hit enter. Sorry, next slide. Disputes and appeals. To help us resolve disputes, we'll need a completed copy of the appropriate form, the reason why you disagree with our decision, a copy of the denial letter or explanation of benefits letter, the original claim, documents that support your position, for example, medical records and office notes. Find disputes and appeal forms have disputes process questions. Read our dispute process FAQs for contact or contact our provider services center. The provider services center is always the best way to start any issue and give them time to resolve it. Next slide, Christy. Wow. Reconsiderations within 180 days, within 45 days. Appeals within 60 days. These are basically the time frames that it takes to resolve it. And there's the numbers on the side or the addresses in Lexington that you can mail to. Next slide, Kristen. Network updates. Updates and availability enhancements. We have enhanced availability in our appeal statuses to include our decision on commercial and Medicare appeals. The decision will display next to the finalized or submitted status. For example, finalized or upheld. Reconsiderations won't display decision information. What you need to know. Select the detailed menu to review the updated status decision. This includes decisions on an appeal that already finalized. If the information is available, the decision will update. If you select the menu for commercial appeals, supporting decision status is finalized. For Medicare appeals, it is finalized or submitted when decision is overturned or partially overturned. You will continue to receive mailed or faxed appeals decision letters. Next slide, Kristen. Updates to skilled nursing and clinical questionnaire. Facilities requesting skilled nursing facilities services for their patients can now complete the new SNF skilled nursing facility clinical questionnaire as with our other clinical questionnaires. This is available on our provider portal on availability. How it works. To go to the authorization, add transaction to submit our authorization request for skilled nurse facility services. We may invite you to complete this SNF clinical questionnaire, which will ask you for your patient's information. The questionnaire is dynamic, so it asks you to verify a variety of questions based
We did it.
on what you've submitted. You may not get the same questions each time you complete it. Completing the clinical questionnaire will either give you an appeal immediately or may give you an approval immediately. Or we may request additional information. If we penned your request for additional information, we'll contact you. Get your tip sheet. Whether or not you can join us for a webinar, you can download a copy of our tip sheet. This guide is available in the resource section of our payer space. Tips for completing the skilled nursing facility clinical questionnaire. Kristen, next slide. Clinical claim review. Prepay DRG fax program. Purpose: to simplify and expedite the claim review and payment by offering additional options for receiving and responding to requests for clinical information. There's medical records requests, submitting requested information, and notes of determination. DRG and peer-to-peer review. Effective December 9th, 2024, Clinical no longer conducts peer-to-peer reviews on readmissions. If a provider does not agree with the clinical Medicare, does not agree with the Medicare or commercial linking, the readmission to the initial admission and appeal can be filed. Next slide, Kristen. Starting July 1st, 2025, we are making changes to our medical plan drug list. These changes support our commitment to high quality, cost-effective healthcare. It is likely some of your patients are taking these drugs. We notify your impacted patients of these changes and suggest they talk to you about changing to a preferred alternative drug, if appropriate. To locate information about medical preferred drugs from the website, Working with Us, pre-cert list, and CPT code search under the pre-certification heading. pre-certification for Aetna providers and patients and care and quality. Next slide, Kristen. Updates, changes to our medical plan drug list. The PDF changes to our medical plan drug list starting July 1st, 2025 can be downloaded under the medical preferred drug list. How do I find information about preferred drugs? You can, next slide, Kristen. I really can't see it. Resources, health, Aetna app. So there is an app that, we all can use, and, everything has an app for that, right? But if you go to the app store, you can download the Aetna Health app and you can get ID cards, benefit details, deductibles, claims, providers, cost estimates, and health reminders. And it's on the App Store or in Google Play. Next slide, Kristen. Resources. Network updates. Aetna public website, Aetna.com. Aetna provider portal and its ability. Credentialing, the credentialing line, clinical information. We have infertility, maternity, disease management, and transplant program. All those numbers there do work in our options to help. Mental health treatment, substance use treatment. See the member's ID card. Pharmacy, there's a pharmacy line. There's a specialty pharmacy line. Provider services, health maintenance, HMO. That's the HMO line. Advantra, HMO and PPO. Identity and PPO, and Aetna, the ASA. Next slide, Kristen. Aetna websites at a glance. Our provider websites when available and Aetna.com are the quickest way to find what you need. Aetna.com, welcome to Aetna. Add a new provider to your group. Review pre-certification lists and tools. Review clinical policy bulletins. Access provider manuals and education. Obtain forms. Can you hear me?
Yes,
Yes,
we can hear
I
you.
can hear you.
Okay.
Yes.
Okay. All right. Submit general questions. Perform existing provider updates. Request pre-certifications. Review claim policies. Access member eligibility claims. Obtain EOBs and submit member or provider specific questions. Next slide, Kristen. Member programs and resources. We offer many programs, and some of your Aetna patients may benefit from. If they qualify, there are no extra charge for them to join. Some of these programs include disease management, case management, end of life, transplant, women, health and maternity, integrated clinical program for behavioral health, disability, and pharmacy, as well as wellness programs, disease management, Aetna lifestyle and conditioning coaching program, fitness programs, and for Medicare Advantage members, Aetna women's health programs, and 24-hour nurse line. Next slide, Kristen. Thank you. That concludes our presentation. I think there are questions
Mention
now.
too. So,
Go ahead.
can you guys hear me?
I can hear you, Kristen.
Hi guys. Sorry, Cloris, I didn't mean to cut you off. I just wanted to
No,
also mention
go ahead.
something new for Aetna on 1/1/26 with the level of severity. I'm sure most of you have either heard of it or are familiar with it. I just wanted to mention it's something new in place, and if you have any questions about it, you can email me directly. It's for Medicare and the dual programs. I just wanted to let everyone know that was something new. And if
Thank
you have any questions or anything, you can email me or contact me directly.
thank you so much. We do have a couple of questions that came through here in the chat box. I will go
Do
over.
see, so you have an EOB, or I'm sorry, the overpayments. That's the question. Refunds and return overpayments. Have you called the provider service center to try to get them to?
They say they also have sent in requests.
Okay. Did you send them to me directly, or you use the provider service center?
Hey, Small, you can unmute yourself and
Okay.
do we have K Small on here?
Okay.
Okay, we'll follow up. We'll ask
Yeah.
for an email and they can follow up with you. Christy
Sorry about that. Can you hear me?
has, yes.
Okay. Um, so yes, we have submitted reconsiderations and requests, and we've called to follow up, and we keep getting that the claims were processed correctly and there is no overpayment due. So we have quite a bit sitting on our accounts to give back to Aetna that we'd really like to give back.
Hi, Christy. Can you hear me?
Yes.
Sorry, I can't always tell if everyone can hear me, but just email me if you can, and information, and then we can go back and forth, and we'll get that settled for you.
Okay, perfect.
My email address in the chat. If
Thank,
you can,
thank
if
you.
you care to email me, I put it in the chat.
Thank you so much for your help with that. We do have an additional question that came in earlier. The question is there a way for patients to change their PCP on the website?
I'm pretty sure there is. And
Mm-hmm.
also you can use the app as well. That there's an app for that, right? But I'm pretty sure there is a way for them. If have they tried? I guess they have been tried.
And worst case scenario, for some reason they cannot get through that way and they're having issues, they can definitely call in as a backup or a workaround.
Right.
Okay. She didn't
Mhm.
specify if patients have been trying. Cheryl, if you want to jump in really quick and unmute yourself.
So our patients come in and they have the wrong PCP on their card. And when they call, it's like a 20-minute wait to try and get it changed. Is there any way that they can facilitate that and just make it happen in real time so they can be seen? Because right now we're turning them away.
So that would be a
I don't,
member services. Yeah, they would have to answer
yeah,
that.
because they'd have to go through that. There's not like a way that we could just be called and change it. Member services handles all those updates.
Right.
So if they have to change the PCP, they have to go through there. They can try the website, but if that's not working, like I said, the only workaround would be to call. And I apologize about the long wait, but that's the way they would change
Well,
them. They
I
can't do it
understand,
online.
Kristen, I appreciate that because I understand you guys are working really hard. But what happens is that not only do they have a long wait, but then, 2 months later, it's still not changed. And
Well, let me know if you have an example, please send them to me. So then
okay,
I can send them over to, we don't have a direct connect, you guys, with the providers, with the members services. That's a whole different thing. So if we could get examples, maybe we can find out someone over there that we could send stuff to. It's just that we don't have that direct connect with them.
okay. It's just the patients are getting really annoyed with it. I just,
Oh, I think they shouldn't be. I
I mean,
mean,
they've
it
been
shouldn't be
patients of ours
this.
for 15 years, and all of a sudden their card says they go to St. Francis. So they don't
Oh
even
no,
think
no, no.
about
Yeah, if it's a problem, they shouldn't be. It shouldn't be taking for. It shouldn't be taking 2 months. I mean, that's not acceptable. So if there's an example of that, definitely let us know because that's the first time I'm hearing of them not being able to change it.
Okay, facts.
Sure.
Thank you. We did have an additional question that came in. Is there a form that we can have them complete and then fax into Aetna for these PCP changes? Oh, okay, that would be member services, right,
I don't
Kristen?
have a
Yeah, I
form.
don't know. Yeah, I don't think that there's a form. I think it's just like we said on the website and to call in.
And we had one other question that came in earlier from Michelle. Are we still utilizing the appeal dispute forms for reconsideration?
Yeah, they should be a part of this. I think, Christy, are you
Mhm.
sharing? I guess you're sharing this.
That was
Yes.
Sharing
me
the,
sharing that because I didn't
Oh,
know. But
yeah, it's
yes,
Kristen sharing it. But I mean, if you do approve your slides to be shared, which was going to be one of my
oh,
questions.
okay. I didn't know this. Okay, I wasn't sure if he was or not. Okay.
Okay.
Yeah, because it should be on the site how you do
sure.
the appeals and disputes, reconsiderations.
I'm just looking for it.
Right.
Let me know if I. Oh, here
There
we go.
there you go.
Okay.
Yes.
Is it on the next slide? I'm sorry. If you need me
Go
to go to
back.
the next slide. Here.
Okay, there are the forms. So there
Yep.
is yes.
To help us
It's two.
resolve. Complete a
It's two
copy of the
links.
appropriate form. Mhm.
Okay, great. Are there any additional questions? And really quickly, if there is an additional question, is it okay to share today's presentation with those who attend today?
No, we cannot share according to legal,
Okay.
so
I just wanted to make sure. Okay.
sure. Thank you.
Okay. Well, thank you again. I don't think there are any additional questions for your great presentation.
Thank you.
Thank you
Thanks
so
for
much.
giving us the opportunity. We appreciate it, Chrissy.
You're welcome. And if you guys do have any additional questions for Christian and Cloris, they did provide their contact information in the chat box. Thank you. Okay, we'll go ahead and we'll move on to our next presentation. This will be from AmeriHealth Caritas, and today's presenter will be Chris Bruitt. Hopefully, I pronounced that correctly. He is the provider network with the provider network management for AmeriHealth Caritas. Welcome, Chris.
Hi, good morning. My name is Chris Bruitt. I am with AmeriHealth Caritas, Delaware. I'm Director of Provider Network Management. I believe I'm still seeing the Aetna.
Yes, Kristen, your presentation is still up. Thank you. Okay. Chris, you can hit the green button at the bottom and it will allow you to share your presentation.
Yeah.
There we go. It's loaded in. Okay, we see your presentation.
All right. So thank you all. Again, my name is Chris Bruitt. I'm Director of Provider Network Management. Walk through a few updates and key items of what we're seeing within the network, and then also as we're working together with the MMA and through our other lines of business, including our ACA and VIP cares. So thank you. As you can see, the agenda here is we'll go through a number of different operational items. First item is our Medicare and Medicaid alignment for January 1st, 2026. Individuals that are eligible and enrolled in a D-SNP plan, they're Medicare and Medicaid eligible, that have that enrollment in D-SNP must be in an aligned D-SNP plan. That means they have to have the same Medicare and Medicaid programs. So if somebody selects, say, DFH as their Medicare, they would not be able to have AmeriHealth Caritas as their Medicaid plan. That's for the D-SNP enrolled individuals. Now, there is a caveat to this. Members, if it's still in 2026, could choose a traditional Medicare plan. They could choose a Medicare Advantage plan and then be with a different Medicaid. So it's very important as you're working together and you're collecting the ID cards from individuals to understand the different types of Medicare plans that they may be enrolled in with primary to see, dictate whether they be enrolled with an aligned Medicaid plan. For billing, as always, the Medicaid is always going to be last payer of last resort. So always bill the primary plan, whether it's an aligned D-SNP plan or whether it's a separate Medicare Advantage plan. We would look for that primary EOB and claims processing through that primary carrier before it reaches the Medicaid processing. Obviously, everybody, I think at this point, EDI is the recommended way to submit claims. It's the fastest, and you're able to see the reports close to real time, a day or two, with whether they're received, rejected, or if there's corrections that need to be made. For our plans, I'm including here our different websites,
Listen to
the various plans.
webinar.
All right. So AmeriHealth Caritas Delaware is our Medicaid website. AmeriHealth Caritas VIP Care is our Medicare. And AmeriHealth Caritas Next is our ACA line of business. The reason we wanted to include all three of these is obviously with the Medicare and Medicaid alignment, and then as individuals may lose Medicaid eligibility, they may have the ability to purchase coverage through the ACA and through Caritas Next product. So these are all various programs that we offer in Delaware. And if you have any questions, you can go out to any of these websites. There's quite a bit of member information, provider information, how to enroll, if you're interested in enrolling and becoming participating with us, prior authorization requirements, contact information, etc. And we did include just enrollment periods for Medicare and Medicaid. Obviously, we're past some of those timeframes at this point. We did host seminars last year as well, but we did include this, and we will update as we move into 2026 with the future dates. If you are a Medicare provider, contracted provider with AmeriHealth Caritas, there is a required training that takes place. It's called Model of Care. This is something that is required with CMS. Sorry, I'm getting some feedback. So there's a few different ways you can receive the training through your account executive. You can also access this through our website. There is a link on there for you to be able to click on and view that. We can fax over information to you, or you can request printed materials, and we would get that out to you. Again, that would be through your account executive. And then we would ask that you complete the attestation that you completed the training so that we can provide that reporting out to CMS. The 21st Century Cures Act, spent a little bit of time on this. I believe everybody is familiar with this right now with the enrollment with the state Medicaid plans. The requirement is that each of your locations must be enrolled with Medicaid directly before you can enroll in contract and credential with AmeriHealth Caritas. You'll receive a MCD ID, Medicaid ID. That ID is a unique identification number that we will request during the credentialing process. We do monitor reports on a daily basis that we receive provider reports from the state as individual providers are effective. If there's an issue with the registration, if for whatever reason there's a termination date or a revalidation date, we do have a team that monitors that and works together with Gainwell on that process. If there are challenges and concerns, you may receive additional outreach from your account executive, especially if it's going to impact claims, because if they do not have a valid Medicaid ID, we cannot process and pay. So just a few examples here. You know, if you have 3 practice locations, each one needs to be enrolled. We'll need those applications completed within 60 days. And then if, unfortunately, we have had this happen in a few instances where providers may need to be terminated from the network if we can't get the enrollment completed. But we do continue to work with you on that, and we also outreach to Gainwell in the state if there's escalations. So we do try to support providers through that process with Gainwell. As you can see, we're providing the Gainwell contact information here as you're working through the enrollment. But again, we also try to work together and help escalate where we can. Another trend that we continue to see, and we actually just, as we're evaluating for last year, is balance billing of members. We did actually see a decrease in this as we're looking at the third quarter data of 2025. We are in the middle of reviewing the fourth quarter overall data for 2025 as well. and we're hoping to see a continued trend downward in that area. But we do get quite a few complaints from members regarding bills being received for services. AmeriHealth Caritas is, again, a Medicaid plan, so members should not be balance billed. The biggest reasons that we are seeing for balance billing is providers, we don't have the primary EOB submitted when there's other insurance on file. Providers, we don't have a claim on file. So could be a couple of different scenarios there. The member may not have supplied their ID cards to you, or you may have an outdated ID card and ID number where the claim is not matching up to the specific member information. So we always ask that providers at each appointment are confirming the eligibility. As I mentioned, third-party coordination of benefits. This is one of the main drivers, and we did see a decrease in this again as we move through towards the third quarter of last year. But if there's other insurance on file, then we would look for that primary EOB for the claim to be submitted to us. At that point, if provider receives a denial for a claim that for other insurance, you can contact us. You can check on the state website to see if there's other insurance as well. And if you feel there's an error in that, as you contact our provider's contact center, they can forward that through to our team that works specifically on the TPL to get that updated and through the system. Now, there are a couple of exceptions where we would not look for the primary carrier's EOB. Related, the exceptions would be prenatal care for pregnant women and for children regarding EPSDT services. We would work together behind the scenes with the primary carriers if we were able to identify that there is other insurance and process that. But those are the exceptions on our end for TPL data and EOBs to be submitted. We talked about member eligibility. There are several ways that you can do this. You can work through Navinet for AmeriHealth Caritas Delaware. You could put in the member's information to get that transaction back. Additional source, I know it's not preferential, but it is an option where you can contact our call center and they will be able to provide that information as well. Obviously, we're going to recommend that you utilize the online services and sources to help speed up and move this through the process rather quickly as opposed to waiting on hold. And here's just some little bit more information regarding the eligibility through clearinghouses. You could work together. There is a real-time eligibility service. Excuse me. So the individual should be presenting their ID cards, as mentioned before. This will include their name, date of birth, effective date. If it is an aligned member with DSNP and Medicaid, they will have one ID card, and you'll have the information all on there. If it is a Medicaid VIP or next enrolled individual, they will have their own separate cards with logos. The other piece, and I mentioned about maybe an outdated card or ID number, we do not collect the cards back from members once they become ineligible. So that's why we do stress that you need to check eligibility each time. Sorry about that. Now, this has been in the works for quite some time, electronic visit verification, EVV, for any personal care services and home health services, effective March 31st, 2026. These EVV documentation and visits are going to be required, and this will potentially impact claims payment for the providers that are rendering these services. I know our team, along with with Mercer as well as DMMA and Highmark and DFH. They've been also working together with providers, providing education, trying to make sure that we have conversations with providers that may be having some issues and concerns at this point. But March 31st is the date that we are expecting this to be live. We do have soft edits in place today where you should be receiving remarks on your remittance if you are if the EBB would have failed, and therefore your claim would not be processed and paid. For EBB, there's multiple ways to check in. So it's whether phone or calling in. I don't know how much more we can say about this. I think it's been in the works for probably 2 years now, plus, if not more. Just trying to get it up and running, and we are finally at the final stretch. Okay, we continue to see common billing errors, duplicate claims, timely filing, authorization, members no longer effective, as well as TPL denials, EOBs, where we need the primary carrier. So your initial claim timely filing is 120 days if we are primary. If we are secondary, then it's 60 days from the primary carrier's EOB. If you submit an initial claim within those time periods, you have the opportunity, if there's a correction or an update, you can submit a corrected claim within 365 days. Please, as you're taking a look at this, we have billing guides on our website. If you are submitting a corrected claim, please make sure you're submitting the correct resubmission codes on the claim and including that primary claim ID within that document. That is one of the biggest reasons that we see duplicate claim denials on corrected claims. So our system reads that as a primary new day claim, initial claim that comes in, and the second claim would then deny for timely filing. So that's a big piece that I want to make sure that everybody works through. If your claim has been submitted previously, please check the systems, log on, make sure that there's no processing. If you're going to resubmit a claim, you feel maybe it didn't get through to us, because that is another reason that we see where maybe for whatever reason there was a miss on a rejection acceptance report. The claim actually got through to us, and then maybe you submit the claim to us, within a week or two after that, and now we have two claims on file, so now they're bumping up against each other, and we don't know which one is the correct one. So that may be, why you'll see a duplicate denial as well. And then again, we talked about eligibility and ID cards. We do offer a prior authorization tool. So through Navinet, you're able to submit prior auth requests. You're able to look on our website to see if a service requires authorization. We've actually added over the last year a date feature to that as well. If there's a future date or whether it's today or tomorrow, so that you can actually see if the service requires an auth on a specific date. As you submit the auth through our system, I know it says receive auto approvals here in some circumstances. They will ask for specific documentation to be submitted sometimes after that. If you've answered several questions and it meets the clinical criteria, the system can generate that authorization. But again, there may be a request for the clinical information after the fact to support that authorization request. If that is not submitted and that authorization is audited, it could potentially hit a post-payment audit, and then it'll request the documentation, and where it's, then it may, if the records are not submitted, may result in a recovery in the future. So just keep an eye on that. If there's additional documents, please submit them with that. I'm not going to read through each of the items here, but the big piece is the supporting documentation to be submitted when appropriate. Access and availability. For prior to 2025, AmeriHealth Caritas has done this internally, reaching out to providers and working through the appointment standards and requests. In 2025, we outsourced this to a vendor, independent vendor, to verify appointments. So they were doing some secret shopper calls to providers. We did see a decrease in the percentages of providers that were meeting the timelines for the appointment standards outlined on the screen across the board for all specialties, PCP specialists, OBGYN, maternity appointments. So we will be reaching out to the offices, just trying to understand what may be happening or impacting as to why we cannot meet these appointment standards. But individuals, PCPs, we would expect 24/7. It's required and outlined in the agreements. There's obviously, if it's after hours, there's specific coverage, whether it's a return phone call or if it's an emergency situation. As you move through waiting time, not to exceed an hour. PCPs, as we go through if individuals do not select primary care physician and they are auto-assigned, then we have a 30-mile radius for individuals, and then that works, and the members then would have to contact us to change their PCP basically if we selected a PCP and they want a different one. For emergency conditions, same-day appointments for PCP and specialists, urgent care within 2 days or 48 hours, and routine care within 3 weeks is what the standards are for the appointment timeframes when we do our outreach. And additionally, we do offer a nurse line to members. It's a 24/7 nurse call line. Members can contact as well, in addition to being able to contact their provider office, and they can help provide direction to members if they may need to go in an ER, or if it's something that based on the symptoms could wait for a follow-up or a PCP visit. So that is something that we offer them. So this is one link to your account executive territory. So individuals, every provider has an account executive. This is going to be updated probably within the next week. We have had some new additions to our team, as well as in Kent and Sussex County. We're working to fill the account executive role for our community physician groups. So as we fill that role, we will be able to update this, and that's why we'll expect it to be updated within probably the week or two to get out onto the website. Your account executive is the same for all lines of business. So for our Medicare, Medicaid, and next, you will have one account executive that you would be able to reach out to. I do recommend if it's just general information or questions regarding claims eligibility, your account executives would not be your first line for that. I would contact our provider services center at the number that's on the screen, and they would be able to assist you with general questions. Now, if it's questions about your contract and or language or rates, then your account executive would be the correct person to reach out to. And with that, open up for any questions.
Great. Thank you so much. We do have several questions that came in through the chat here. Question here is, let me scroll way up. Okay. When there are coordination of benefits issues and patients refuse to call to update their COB, how can practices pursue action if not by sending a statement to explain to their patients?
So the provider's office, they got a rejection from us or denied claim for COB, and they've been outreaching to the member to try to get assistance. On our website, there's a let us know form. If you can reach out to us via that form and explain what the issue is, we have a team, it's our rapid response team. They can work together to also try to outreach the member and gather the information for the member. If that member is also in care management, they would work together with them to try to outreach the member and gather information as well. So I would utilize that let us know form to kind of help move that along with our internal resources.
Great. Okay, thank you. Another question came in. Bristol says that they work imaging offs for a urological group and have seen a lot of denials for imaging come through with a rationale of no clinical documentation. However, when going into RAD MD, you can see the entirety of the patient's clinicals attached. I have also received confirmation for clinical email. Can you give any insight into this? Also, these questions are more claims, more claims related questions directed specifically for their office. Can they communicate with you, Chris, via email?
Yes, and what I would ask in that particular situation regarding the radiology authorizations, I do not have any insight. I would just, if you could send me an example or two that I can work together with our teams to try and understand what's going on with that. I have not heard that before, so I would just need to look into with the appropriate areas to see what's going on there.
Okay.
But yes,
Can
you
I
could. Yeah,
can I put your email in the chat box for you?
Yes. Yep.
Okay.
That works.
Okay. I'll go through these questions and then I'll put his contact info with his email in the chat box. The next question following says, related to the above question for Christopher, what action should we take when we find that the patient has purposely neglected to inform the provider of their primary care? We have encountered patients who feel that they only need to report to their Medicaid.
I would say utilize that let us know form so that that can get through to the appropriate teams that can do the member outreach. And if it's education, again, our team will do that also as well with the members. I know they do receive that information up front, but if they can work together on that and utilize that let us know form.
Okay. An additional question came in. I imagine quite a few of your duplicate and timely filing issues are also related to COB issues because we often don't find out about an issue until the originally billed primary care audits a year or two later, and then we have to bill the correct primary. A process for COB related issues in general would be greatly beneficial to both providers and you as a payer. I don't think that was more so of a question, unless I think it's Chrissy Smalls, unless you want to elaborate.
Yeah, so I mean, I guess I'm just looking to see, is it possible to have something dedicated for COB related claim issues? Because, I mean, we're obviously just having to bill with the original EOB, then it's denied for timely. Then we go through a whole appeals process, sometimes with 2 different appeals. And we wouldn't have known there was an issue if we got paid by who we billed as primary originally, right? So we're looking now, it's a year or 2 later, patient's phone number has changed, we can't get any information from them, and we're just beating around the bush trying to get paid. Meanwhile, the money has been taken back from the original primary payer. So is it possible to set up something related to COB issues to actually be able to navigate this better for both the providers and the payer?
So these are, I'm just going to say Aetna because they were on right before me. So Aetna is the primary payer. You go through the appeals process with them, and then by the time you go to submit the claim to us, it's a year or 2 later, and then it hits our
Yes.
filing denial.
Yeah.
Okay. Yeah, and so I will have to take that back.
I imagine that if there's a
generally-
way for a claim to be like noted as a COB issue or something in some way, or sent in a different manner, that a team working just those would probably be a lot easier than going through multiple appeals, or denying for duplicate, denying for timely, and having multiple people work on this rather than just be able to process that claim as it was a known COB issue.
Got it. Yeah, let me take this scenario back and see what I think once it hits that 12-month mark is when it may not hit like a pen queue for somebody to review possibly. But I just need to verify if somebody's generally what happens with our COB, if all the information is there, it could potentially auto adjudicate and coordinate the benefits. If there's something that would cause, a question, then it would pen for a manual review through a claims examiner. But I don't know what timelines and the instructions that those examiners have. So I have to double check on that and with our network ops team and claims team.
Yeah, appreciate it. Thank you.
Okay, we have a few more questions here. Our office sees a lot of we don't talk between parents, and therefore one parent does not know the other's coverage half the times. I don't know if Steph Stevenson, you want to pop in, unmute yourself and elaborate a little more.
Oh, I think I understand the situation because I help coach a high school wrestling team, and we deal with that as well with kids that get injured, and then one kid goes and doesn't know about. That again, I would say if you're running into those scenarios, utilizing that let us know form to kind of explain, hey, here's the situation. Our teams then may have contact information for each of the parents to be able to do outreach and gather documentation. It's a difficult situation to navigate. I get it, and fully understand that. And I think that's probably going to be the best recourse to that way. It's not putting you necessarily in the middle of 2 individuals that don't want to speak to each other. And we can maybe approach it from our team is talking to each parent individually and seeing what we can collect and provide information.
Thank you. Question came in here. How do we get a care coordinator for the dual eligible? I guess to help their office.
I'm sorry. You're looking for someone to.
Yeah, they says, how do we get a care coordinator for the dual eligible, that extra help?
So That I would work through our VIP contact center. So I would go out and contact them. They would be the ones that would be able to. They may ask some specific questions about the member, and then be able to provide the assistance on that front. I'm not sure exactly what assistance or help would be needed, but I know our teams do assist the members directly as well if they have questions about Medicare enrollment and or coverage and what their options may be. And they, whether it's a clinical question, if it's administrative, then they may also direct them to a, lack of a better term, I believe it's a broker of sorts to be able to explain all their potential options to enroll through that process.
Okay. This question came in regarding PCP chains. Rather than the question is there a faster method to change the PCP? They've run into cases where their PCP, where we were the PCP the previous month, and then the PCP is changed the next month. Do the
Those
patients have to
changes are
call?
generally,
Do the patients have to call,
yeah,
or can they do it online? Because this question came up earlier for Aetna.
I do not know if the members have the ability online to do that. I know calling our member contact center would be able to start that process as well. But I'd be curious to understand why there would be a PCP change if the member had not requested it. So if that could also be sent to your account executive as the contact center to say, hey, here's what we're seeing. And can we share some information on that? Because I'm curious as to, we're generally not making, actually, we're not that I'm aware of, not making changes to PCP enrollment unless a member or somebody has made that authorized on their behalf to make those changes if they're already established with
So
the PCP.
this is Cole Legge from Delaware First. I think that one of the few examples that we'd have is if there was a provider termination, we would work with the member that it was not a member initiated provider change. So in the instance of death or term or sanction, we would initiate that on our end, but would be sending notification letters to those members so that they were aware of those changes. So there are some non-member initiated changes in the PCP space, but they're not, I don't want to say not frequent, but they're not as often as member initiated changes.
Agreed, but I read this scenario as it appears this provider is still participating with us, and the PCP was changed for whatever reason. I agree with Cole. There are some, but that would mean that the provider's no longer participating, and they wouldn't have any panel assigned to them at this point with our members.
Okay. Another question here. How do you suggest we handle claims where the primary was a motor vehicle accident and PIP has paid partially, or if it's applied to their PIP deductible?
So we would need the letter and or information related to that submitted with the claim, so that we can coordinate those benefits. We do know, in that way they could also log once if there's an exhaustion through, say, a motor vehicle accident. If that benefit is exhausted, that way we can document that and would then look to pay, as primary at that
Can
point
I
moving
just
forward.
piggyback on my question? If PIP had a deductible, do you cover that deductible?
That I will need to double check. Let me double check on that before I give wrong information. I believe I know the answer, but I don't want to give incorrect info.
Okay, thank you very much.
Thank you. We have one more question. In reference to the COB issue and having the physician's office utilizing the tool, at what point is the patient responsible and accountable again to have the physician's office to inform you it is not our responsibility?
Can you repeat that? I'm
So,
sorry.
can you read
Sure.
that question again?
Yes. In reference to the COB issue and having the physician's office utilizing the tool, at what point is the patient responsible and accountable? Again, to have the physician's office to inform you is not our responsibility.
So, as far as the Medicaid plan goes, we cannot balance bill members, right, for the Medicaid covered services. I would that's where reaching out to us to be able to assist with that would and provide that member education and outreach. We would be able to help. I don't, we do outline that as the member's responsibility to provide all insurance coverage and information. We will do that education. But as far as being financially responsible at the end of the day, that's, regarding that balance billing, if there's ongoing issues and concerns, then if we have the primary carrier's information, we be able to work together with you on that. But I don't know that I think the question is leading to when does it become the member's financial responsibility and accountability on that front. And again, as a Medicaid plan, then you would not be able to bill the member for those covered services.
Okay, there's a follow-up question regarding to the let us know form. Once they submit the let us know form to AmeriHealth, how do we know that your office received it and are reaching out to the member or the parent?
I will double check to see if there's an acknowledgement response sent back to the provider offices. I thought there was, but I will double check on that.
Okay, thank you. Thank you so much. Our time has run out for AmeriHealth. I have put in his email address if there are any additional questions that come up later on today in the chat box. I want to thank you again for a great presentation. That was a lot of questions. Thank you for being able to assist in answering those.
No problem. Thank you.
I do have one question, sorry, for me. Is it okay to share today's presentation with those who attended today?
I did send a message. I heard that at the end of the last presentation. I'm checking to make sure that there's no issues with sharing it.
Okay. Okay, thank you so much. Thank you. Thank you again, Chris.
Mm-hmm.
Our next presentation is Cigna, and we have Catherine Leonard Nixon. She will be presenting today on behalf of Cigna. Thank you so much.
Thank you. Good morning. Can you hear me?
Yes.
Okay. Good morning, everyone. I just want to say it's a little bit chilly here in Northeast PA, and I'm kind of suffering from a little sinus issue. So I apologize if I'm a little nasally. But I did want to say thank you for allowing us to join the presentation, and wanted to let you know that the presentation is available to be shared after the workshop. So everyone can have a copy of that. That's certainly not a problem at all. So I just wanted to kind of start with, this is our commercial business. So we do have a dedicated support service team. We do provide revenue cycle management support, as well as medical, pharmacy, and behavioral information. We also do provide drug benefit information at the time of care for enhancing our patients. And we do provide specialized digital tools as well as concierge service as well for all of our members. And we'll start a little bit into our digital systems and solution networks. So we do work with multiple providers, and part of our cost-effective care is networking with our multi-employer groups. And these are just a few that we do service. With that, then we are also a global healthcare company. I realize that this is a Delaware, but Delaware is actually part of our Liberty Valley network, and that includes Ohio, Pennsylvania, West Virginia, as well as Delaware. So even though we are a global company, those services are available as well. And then I'll jump into our digital solutions. And we have convenient, easy digital tools that can help you with your office workflow, increase productivity, save time and money, and access the patient information, as you need it. With that, we do have our Cigna for HCP.com, our portal, and that allows you to verify benefits and eligibility, look up procedure codes, check on the claim status, submit reconsiderations, appeals, pre-service, pre-certification, as well as any updated policy information. We did recently also come up with, for lack of a better word, it's called Cigna, the provider newsroom.com, and that's actually open to anyone. And again, it's providernewsroom.com. I don't have it in the slide here. And that will allow you to get any updated information that we have as far as any policies and procedures, any information that is new and on the horizon, that will be published out there as well. So we do kind of have two methods of information available to you. With this, we also do encourage claim process through electronic data interchange, and auto adjudication obviously is the best way, to do things. So it's a little bit easier to track. You have that little bit more of flexibility, and these are some of the benefits that we do have with regard to that. We have a streamlining payment process. We do prefer electronic funds transfer and EFT. This way, then you can easily get one payment for multiple claims, as well as then we do give you the electronic remittance advice as well. So it's a lot easier for you. Everything is one touched and right there at your fingertips for you. We also offer easy access to your payments. You can review all of this online through the Cigna for HCP.com once you're enrolled in EFT. We also have our national ancillary providers. And here's just a few that we do have for our chiropractic, home health, laboratory services, PT, OT, as well as then vision and sleep management. We do have a local presence in the market, and this information is available for you easily to access. Like I said, in this presentation will be sent to you after today's workshop. Now, we do have some policy updates. As you may be aware or may not be aware, that Cigna did sell their Medicare business. So that Medicare business currently right now is under the operation of HCSC.com. Our Cigna employees were migrated over to them as well. So we do still maintain somewhat of a dotted line. But as of January 1st, they were going under the auspice of HealthSpring. So that is what was currently the Cigna Medicare, is now going to be called HealthSpring, and that is owned by HCSC. And then we do have some pre-certification policies that we've updated. This information is out there on the Cigna for HCP.com. We've also taken 96 codes that did require pre-certification, and so make it a little bit easier for you. But we do have a very inclusive list out there, and it is easy to access. So please take advantage of it if you haven't already been using it. We'd appreciate that. And then now I'll talk about our claim submission and payments and our appeals. So we do use the EDI, and the claims do come to Cigna on an 837. And of course, you receive your payment information on the 835. You're very well, acquainted with this response. But here's a little bit more detailed information on this slide. So you can certainly, overview that when you have some time. And then our claims 360. This gives you the flexibility to kind of go out there, view the results in a table. You can filter, you can download, you can view all your claims at an organizational level, and that is based upon a TIN. So if you are a huge facility and you have multiple TINs, you can download all the claims, based on that TIN, and then be able to filter and sort and handle it off to your various departments as needed. And then here's a little kind of a detail on how you can go in and search in our Cigna for HCP.com with the patient information. So you would go to the search, you would type in the patient. From there, you would actually then put their information in as far as their AMI, alternate member identification number. And then you could pull up the claims that are associated with this particular patient if it's on an individual basis that you're searching. And then you can certainly download that information and all the results. And then we also do have where you can upload some documentation for pending appeals, whether it be needing a primary EOB, some additional notes for history and physical that may have been requested for the claim. That can all be done on this portal as well. And just some more information as far as, what's able to be uploaded, the maximum size, and the file types themselves. We do offer some additional training that is available out there on navigating our Cigna for HCP.com. So if you are looking to expand, to have multiple members being able to go out there from your organization, there is that training available for them. And we do have a Cigna website team that can assist if you do run into some errors or some issues that, you're not being able to find what you're looking for, you're having some system connection issues. They'll certainly troubleshoot with you. And then we do have the claim reconsiderations and the appeals. You can do this online as well. All of that is out there for you on our portal, and a little information as far as step-by-step guidance on what you need, how to, select that you'd like to start a reconsideration, etc. And then our provider resources and our contacts. Like I said, we do have our Cigna for HCP.com. Out there, you can get our information as far as downloading our reference guides. And obviously, I didn't realize that this was here now, is our provider newsroom is available as well. So that kind of gives you multiple avenues for researching, trying to get answers to your questions, to do it initially online. And if need be, then if you can't find the information, your designated provider relations representatives are available to help you as far as researching that specifically for individual needs. as well as then also calling into our customer service department and our provider service unit. If need be, they can actually assist you for additional information. And then we do have free webinars. We have quick reference guides for ID cards, looking at multiple ID cards to kind of understand what is what you're looking for as regard to if it might be an IFP plan from another state, if it might be your local plus, which or open access plus. All of that information is available on our quick reference guides, as well as then calling even our provider service. And some information if you are doing any demographic changes for your providers, you are having them go from one facility and going to be practicing at a few more locations. You can submit that information to our intake PDM at Cigna.com, and they'll be able to update that provider's profile for you, as well as then you can fax that information in or email, and then hospital and ancillary changes as well. So the only thing that really is that I would caution is if you have a brand new provider who is fresh out of medical school, just moved across country to Delaware, that actually will be handled by our medical onboarding and not by our provider data maintenance team. That is really the only stipulation between the two, is just that our medical onboarding strictly is for brand new, like I said, fresh out of medical school, new to the state of Delaware, have never practiced in Delaware at all. That information will be done by our medical onboarding. If they are a practicing provider within Delaware and they are moving from Nemours to Christiana or down to Bay Health to BB, then they are already probably in our system, and that change of information would then be handled by our PDM department. So just wanted to clarify the difference there. We do get some confusion with regard to that. And that is it for my presentation. Are there any questions?
Thank you so much for your great presentation. There is a question that did come through. The question says here, we have some issues with a third-party insurance that utilizes Cigna, MagnaCare, who is sending payments directly to providers, causing tax issues. We have reached out to both MagnaCare and Cigna to try to get this corrected, and both are passing the responsibility to the other. Meanwhile, we cannot cash these checks without causing issues for our providers. How can we get this resolved?
Okay. I am not familiar with MagnaCare, but I can certainly, if you'd like to provide my email, I can certainly look to see if you can give me a specific example or two with regard to the Cigna patient, the ID number, the claim, the date of service, something to kind of help me reference that. Then I'd be happy to kind of get that. If it's not something that I handle specifically, then I would be happy to direct that to the person who would handle that. There's myself and another one of our provider relations managers that primarily handle the Delaware area and the Delaware market. So we can certainly get that to the right department. If it's not myself, it might be Lisa. And if not, then we can certainly engage our other partners to assist you with that.
Thank you. I did put your email address in the chat box, so if anybody does have any questions for her, feel free. Are there any additional questions for Catherine? Okay, looks like we're good. And you did say we could share this presentation, so sometime after today's session, I will forward the presentations to everybody who attended today. Thank you again for your great presentation. Okay, so our next presenter is from Delaware First Health, Lindsay Short and Nicole Evans for the provider engagement of Delaware First Health. I want to welcome you too. Thank you today. Thank you for joining us today.
You're welcome. Can you hear me?
Yes, and we do see your presentation.
Wonderful. Oh, I went too far. Sorry. Good morning. My name is Lindsay Short, and I am a provider engagement account manager for primary care providers in Kent and Sussex counties under Delaware First Health. Next, I will list our agenda topics. We will have an introduction, plan updates, provider partnership, member supports, questions and discussion. Here at Centene Corporation, the parent company of Delaware First Health, we strive to transform the health of the communities we serve one person at a time. Centene Corporation serves 28 million members across 50 states. There are 3 Delaware market products: Delaware First Health Medicaid, a managed care organization plan focused on high-value care. And Better Health of Delaware offers high-quality marketplace plans, and WellCare Delaware provides Medicare Advantage prescription drug plans and dual-eligible special needs plans. For plan updates, on January 1st, 2026, Delaware moved from coordinated to highly integrated dual-eligible or HIDE care. The HIDE model streamlines care delivery, and members will receive comprehensive support, ensuring better healthcare outcomes and easier access. Since January 1st, 2026, Delaware requires that all care is managed at the HIDE level. This means that HIDE plans must be affiliated with the Medicaid Managed Care Organization, or MCO, ensuring better alignment and coordination of services. This shift is part of a broader effort to streamline care and improve the health outcomes for Delawareans who are dual eligible. Okay. Our other plan updates, we have dental updates and NCQA updates. These ratings reflect solid member experience, clinical quality, and service performance. In addition, Delaware First Health is the only MCO in Delaware to achieve NCQA's Long-Term Services and Supports, LTSS, distinction, recognizing our strong person-centered approach to coordinating complex LTSS care. Now I will turn it over to the Supervisor of Provider Engagement, Nicole Evans, to discuss provider partnership and member supports.
Thanks, Lindsay. Good morning. Can you hear me okay? Just checking the volume.
Yes.
Thank you. So for provider partnership, our mission with provider partnership is to provide practice level support with clear communication and prompt follow-up while focusing on reducing the administrative burden on your office. Our model allows us to support quality member-centric care and address your concerns in real time. Next slide, please, Lindsay. So with that being said, we have amazing, phenomenal provider engagement account managers that serve as the primary point of contact for practices and providers. Our representatives support payment-related inquiries, claims navigation, and provide important plan updates. Now, our team will coordinate closely with other departments within the Delaware First Health organization to ensure timely resolution of issues. We view our provider meetings as a family environment, so we're focused on collaboration and supporting quality care. You'll hear more about these other departments in the upcoming slides. Next slide, Lindsay. As a billing reminder, claims must include required taxonomies. You've heard that in other presentations. However, this is important because accurate taxonomy reporting ensures proper claims processing and timely reimbursement, while also supporting your office and maximizing payments. Claim reports are provided to those offices that meet with us on a monthly basis. However, for those offices that don't meet with us regularly, you may frequently receive an email if your claim denials exceed 10% or more in a single month. Please check your spam. We encourage everyone to reach out to provider services and/or contact your provider engagement account manager for support. Now, by working together, we can streamline claim submissions, reduce denials, and strengthen our partnership in delivering quality care. Next slide, Lindsay. So as a reminder, we ask that you follow the claims dispute process for any claim denials, which include submitting a reconsideration, which can also be followed up by an appeal. Those steps are outlined below. Your provider engagement account manager would be happy to walk you through on how to submit those reconsiderations using our secure provider portal and/or just for support at any time. You can also find additional information regarding appeals in our provider handbook, which is located on our website. Next slide, Lindsay. Thank you. Now, part of our collaboration includes a quality practice advisor. They will serve as the primary liaison for quality improvement. They work closely with your provider engagement account manager to support quality improvement initiatives. There's education for providers regarding the NCQA HEDIS measures, risk adjustment, documentation, and coding best practices. Our quality practice advisors also assist with closing quality care gaps and improving overall compliance. They also support initiatives and provide audits to strengthen performance outcomes. Included within your provider meetings, the quality practice advisor serves they provide an overview of performance data, such as your pay for performance earnings, earned versus potential, a summary of your HEDIS measure performance, member and provider level performance details, and then your overall member satisfaction score. Next slide, Lindsay. The COC Plus program provides an opportunity to earn additional compensation by using the appointment agenda as a tool to guide patient encounters with our members. Ongoing support is provided by our team. That appointment agenda combines a health condition history, HEDIS measures, pharmacy, high risk, clinical, and drivers of social determinants of health insight. And next slide, Lindsay. So the purpose of the COC program is for our members to benefit to receive regular and proactive assessments for their chronic health conditions. This program is designed to support outreach for our members for annual visits, and this also helps Delaware First Health better identify members who are eligible for care management. Now, we do offer bonus payments for proactively coordinating with preventative medicine and thoroughly addressing and documenting patients' current conditions to improve health and clinical quality of care. Next slide, Lindsay. So for education and training, some of our 2025 successes, we had 120 registrants for our joint MCO provider resource fair. This is just an example of we've collaborated with the other MCOs to streamline processes and reduce duplication for our providers. We've had 10 in-office provider events, 4 provider advisory council meetings, and we do a targeted hand-on education approach through sessions with our providers. Now, ongoing opportunities. Clinical documentation improvement CDI webinars are available. You can visit our website for a full listing of available trainings and education. And we absolutely love on-site tabling events at our provider offices, advancing member education. Next slide, Lindsay. In addition to our interactive support, we offer several resources for you to access quickly. That includes our provider website and the manual. Some of the forms which we've heard come up previously that are available is our PCP change form, provider data updates, annual attestation form, interpretation services request form, just to name a few. Next slide, Lindsay. We would love to feature your practice in our provider newsletter. We also have EMR connectivity and bidirectional integration. Some of our other opportunities include collaboration on engagement initiative that support our providers, strengthen workflows, and improve member experience and outcomes. Next slide, Lindsay. As we look ahead to 2026, our goal is to continue building on the strong foundation we established this year. We will maintain close collaboration with our provider network community by continuing to feature job openings and training programs in our newsletters. We also plan to explore opportunities to highlight our network through future provider spotlights. Another priority that we have ongoing is to partner with the MCOs. The job fair we co-hosted this year was a success, and we continue to organize more events like this to support our member employment journeys. If you participated in any of our events this year, we truly thank you, and we appreciate your engagement. If you're interested in participating in a future job fair or would like us to feature your job openings and or your training programs, please do not hesitate to reach out to us at workforce at the email address provided on the screen. All righty, next slide, Lindsay. Now, in ways of member support, transitioning the health of our communities one person at a time is more than just a mission for Delaware First Health. It's our daily promise. We put our members at the heart of everything that we do, and we support your office every step of the way by removing non-clinical barriers, such as interpretation services and transportation. Every provider meeting is backed by a dedicated member advocate, ensuring that your team and our members are empowered to thrive, details of which we'll highlight on the next slide. And thank you so much, Lindsay. Our member advocates help members who may have social needs that make it hard to get care or services on their own. We support our members by helping them navigate health and social service systems, promote self-management and health literacy. We follow up to ensure that their needs are met. We engage our members at community events, support them with grievance and appeals. Now, this form right here is our member advocate outreach form. This will allow us to support your office by outreaching those members that may be hard to get a hold of for your office. And this also allows us to address any social determinants of health that your patient may need. Next slide, Lindsay. Our value-added benefits is something that we are very proud of here at Delaware First Health. Some of the highlights include home-based asthma support. Members with asthma get $250 per year for non-clinical in-home asthma support, such as air purifiers and allergy-friendly bedding. Our blood pressure self-monitoring program is for members that are 18 and above. They can join this 16-week program to help lower and manage their blood pressure. All of our value-added referral forms are found on our website under provider resources, and you can visit delawarefirsthealth.com/VAB for a full list of our value-added benefits. Next slide, Lindsay. Now, we do have a list of our My Health Pays awards. It's currently listed on our website. These are some of the initiatives here on the screen that the members are reimbursed for. Those rewards can be spent on utilities, transportation, telecommunications, childcare services, education, rent, and then those everyday items purchased in store at Walmart, excluding alcohol, tobacco, and firearms. Next slide, Lindsay. Thank you. Our EPSCT coordinator is here to partner with your office, offering support while servicing members from birth through age 20. This helps ensure that every child and young adult receives the care that they need. The focus of the coordinator is to support provider outreach, such as providing annual reminders to your patients regarding their preventative care. Next slide, Lindsay. Our case management and care coordination team is also available to assist members with complex medical and social needs, helping to prevent disease progression. The team facilitates access to appropriate care and ensures follow-up between visits to support provider care plans. We encourage providers to refer members directly. Additionally, our risk adjustment member assessment program offers in-health home assessments to identify chronic conditions and care gaps. We use advanced data analytics to target eligible adults to complement PCP visits when additional support is needed. Next slide, Lindsay. Thank you. So we sincerely want to thank all of our providers who have chosen to meet with us regularly, dedicating your time and expertise to our team to drive meaningful change in care of our members. Your commitment to meeting with us on a consistent basis allows us to work together to improve health outcomes, close care gaps, and make a real difference in the lives and the communities in which we serve. We are deeply committed to supporting your office in every step of the way, partnering with you to overcome challenges and celebrate successes as we advance towards quality care together. And thank you to everyone on the call. As I see some familiar names out there that has chosen to meet with us regularly, we greatly support everything for your office, and we thank you so much for meeting with us. Are there any questions?
Oh, thank you for your great presentation.
Thank
We
you.
do have one question here. How might a urology practice be highlighted in the provider newsletter?
Great question. Absolutely. We would love to connect with you to support you being highlighted in our provider newsletter.
Can I provide a contact
Yeah,
information? Okay.
I'm going to put my email address in the
Okay,
chat. Thank
great,
you.
great. Thank you so much. Are there any other questions? Okay, I think we're good. And it's okay
Okay.
to share your presentation?
Absolutely.
Okay, great. Thank you so much.
Thank
Okay.
you.
Thank you guys for a great presentation. Okay, so our next presenters are from UnitedHealthcare, Amber Frost and Michelle Lentz. I don't know if it's Michelle or Michael Lentz.
It's Michelle. You got it right.
Michelle. Okay, wasn't sure. Provider account management team for UnitedHealthcare.
All right. Good morning. I want to just make sure we can hear Amber too out there. Amber, you may be on mute.
Looking for her name.
All right. Well, I have the first part of our presentation and I can start, and then hopefully Amber can figure out the mute issue here as we get started. So let me share my screen really quick.
Okay.
And let me go ahead and try to do this.
Okay, yes, and I do see her on.
Okay. Are you able to see my screen?
Yes.
Is it a split view or is it okay?
It's a split view. Well, it's I we see your presentation and then this upcoming slides.
All right. Well, I'm trying to see here.
Okay.
Let's see here. How about now? Are we okay?
It's the same,
Oh,
but
okay. Well, if
that's
you can
okay.
see it, let's roll with it.
Okay.
Little technical difficulties. So good morning, everybody. I'm Michelle Lentz. I'm the executive director for our Medicare and D-SNP programs for UnitedHealthcare for Pennsylvania, Delaware, and New York. And I wanted to spend just a few minutes, the first couple minutes of our presentation, talking about chronic SNP plans. So these are newer plans in kind of that Medicare Advantage space. So I wanted to start out and just talk about what they are, what makes the benefits a little bit different, and then go into just some national trends that we're seeing on chronic special needs plans. So just to get started here, so these plans are one of three type of SNP plans, special needs plans that CMS allows us to offer. So you're probably all very familiar with dual special needs plans. There's institutional special needs plans, and then there's chronic special needs plans or CSNP. And these are plans that are available to individuals that have certain chronic conditions. So for our UnitedHealthcare CSNPs, there are three chronic conditions that would enable a member to qualify for these plans. So the first is diabetes, the second is cardiovascular disease, and the third is CHF, chronic heart failure. So this data is about a year old. We launched our first CSNP plan in Delaware last year, and nationally we've had them for a few years. But we estimate about half of the members in Medicare Advantage plans would be eligible for a CSNP based on having one or more of these clinical conditions. So very kind of impactful to the members that are eligible for Medicare programs. One of the things I wanted to touch on is because we think, well, why would someone want to choose one of these plans, right? What differentiates it from another Medicare Advantage plan? So these are just some highlights from the UnitedHealthcare plans. So one, we do ask members to choose a primary care physician. We know that members with these chronic conditions do typically see multiple specialists. So from a care coordination perspective, we feel, it's very important for the member to kind of have that primary care physician in place. These members do qualify for a special election period. So if someone newly qualifies with one of these conditions throughout the year, they are able to select a C-SNP plan outside of the typical annual enrollment period. We do offer specific clinical management programs for these members, a specific nurse line. There's education for members with these conditions. So from a support perspective, there's some additional resources that we do coordinate with these individuals. But I think one of the most impactful is there's a unique benefit package available to these members. One of them is that, we do offer healthy food in many cases. When we had dual plans in Delaware and like others, healthy food is a typical component of a dual special needs plan. But members in a C-SNP also qualify to get that healthy food, which we know really encourages eating healthily and, can help with managing some of these chronic conditions. I think the other very impactful piece is that there's a unique formulary for these C-SNP members. So typically you see lower deductibles, lower to tier 2 retail copays. And we also have many of the medications down tiered. So things that would traditionally be on a tier 3 fall into a tier 2 for these members. So I think,
Michelle, I'm so sorry. Your slides aren't advancing.
Okay, you don't see attributes of chronic SNPs?
No.
How about, what are you seeing now?
I just the very first slide.
Oh my goodness. Technical difficulties at its best here. Let me see. Amber, are you on yet and able to share? Right, I'm going to try to just share again here. Can you see in this view?
No, I just see your just your view, like your name.
Oh my goodness. Let me go back here. All right, let me try to share again here.
Okay, so now I see the chronic condition special needs.
Okay. Is it advancing?
There we go. Now.
All right. We're going to go with this then. Okay.
Okay. I
Sorry
see
about
attributes of chronic.
All right. That's what I just reviewed then. I was talking about the formulary and the lower copays and the healthy food. So I did want to touch on for a minute. Hopefully you can see it's a slide about the verification process. This is where I think this becomes pretty impactful to our physician partners. So CMS does require that we validate the member has one of those conditions within 60 days of the effective date. So again, we're validating if they have diabetes, CHF, or cardiovascular disease. UnitedHealthcare will look at all of our data internally. So if there's claims data, if anything's available to us that we're able to validate those conditions, we do that first. However, if we're unable to validate, so for instance, if a member is new to UnitedHealthcare, we may, have to reach out to the provider, the associated providers, to validate those conditions. And again, that's a CMS requirement, and it has to be done within 60 days. So that is something unique to these plans, that verification requirement. So if, you're getting some fax requests, things like that, we're trying to adhere to that CMS requirement to validate those conditions. If for some reason a member is not verified or validated, the CMS default is to put them back into original Medicare. UnitedHealthcare would certainly reach back out and try to find another plan that would fit their needs, but they would not be able to stay in that chronic special needs plan if they're not validated. So a very important process. Just really quickly, this is a snapshot of UnitedHealthcare Delaware plans for 2026. In the red box, you can see we have 2 C-SNP plans. You're seeing 3 just because one of ours has multiple group numbers. But there are 2 C-SNPs available in the market. And again, both of those fall under kind of that Medicare Advantage definition in the provider agreements. So I'm going to spend a real quick few minutes on just some national data trends on C-SNPs, because these are growing very, very fast in that Medicare Advantage space. And this is not UnitedHealthcare data. This is from the ATI advisory study on trends in C-SNP enrollment and offerings. So just a couple key takeaways. I talked about what are C-SNPs, but a summary of the study basically shows that when we look at C-SNP enrollment, it grew by 67% from 2024 to 2025. So very fast growing. And what we're seeing is that members that are dually eligible are actually shrinking as a piece of this enrollment. And that's not surprising, with CMS integration requirements and some of the other things going on. We are seeing that D-SNP membership kind of, go out of C-SNPs into D-SNP. What we did see that 96% of chronic plans offered across the country have either cardiovascular conditions or diabetes as one of the conditions. So almost every C-SNP you see are going to qualify if you have cardiovascular conditions or diabetes. What we're seeing is 95%, almost all of the enrollment in C-SNPs are coming from original Medicare or another Medicare Advantage plan that's not a SNP. So again, very few members we're seeing coming in from either D-SNPs or institutional plans. Most of these members are either coming new to Medicare Advantage or from another Medicare Advantage plan. And then for that small portion of members that are D-SNP coming into them, what we see is that the D-SNP members choosing to select a C-SNP are most often those that are no longer eligible for dual enrollment. So this is like, a really good landing place for those individuals that no longer qualify or no longer dually eligible. Right now, today, about 1 in 5 enrollees are dual eligible, either full or partial. So this is just a quick graph showing those SNPs, the dual, the chronic, and the institutional. This is national enrollment since 2016 through 2025. And this just shows you how quickly these plans are growing. So D-SNP is that top black line. You can see much more enrollment in D-SNPs nationally, about 6 million members. But I did want to highlight that bluish line in the middle is the C-SNPs, and you can see that steep kind of increase in enrollment from specifically 2024 to 2025. So definitely a growing component of the Medicare Advantage landscape. This really just shows you the number of C-SNP plans available across the country. And basically what I wanted to highlight here is over the last 5 years, from 2020 to 2025, the number of these plans more than doubled. So this is something I think you're going to be seeing a lot more of. And I think, the trend is continuing to grow in this space. Then just to highlight again, these slides just kind of demonstrate those summary facts that I stated a little bit ago. This just shows you to the far left, C-SNP enrollment. So this is members coming into a C-SNP, which is in the blue, 323,000 members, and members leaving C-SNPs, about 104. So it is, the delta is about 218,000, still definitely growing year over year. But you can see in the next two little sections, the majority of that 323,000 is coming from non-SNP Medicare Advantage. That's that 262,000. And then the Medicare fee-for-service or original Medicare, that's the 35,000. So, biggest component, again, are those two buckets. And then you can see there is a little bit of D-SNP membership nationally coming into those plans still. What this shows is just that decreasing percentage of D-SNP members. So on the far left in 2023, you could see at the very bottom, the dark red piece is the full dual membership component, which was about 15%. As you go over to 2025, there's two graphs for 2025. You can see for total C-SNP enrollment, that dropped to 12% from 15%. And then for those members that are newly in a C-SNP, so no renewals, no members that have historically been in there, it's even smaller. It's about 10%. So definitely seeing that trend. So, just to recap quickly, I wanted to just talk through what a C-SNP is, what type of members qualify. We do have that verification process, unfortunately, that I know is a little bit of growing pains. But hopefully, we get better and better at that process, and UnitedHealthcare would like to validate, as many members of as possible. And then I just wanted to share kind of national trends, because I think this is definitely something that we will see more of. And, it's definitely, I think, going to continue on the trajectory of growth. So any questions on this portion?
Thank you. There was one question that came in. Is it necessary for the patient to possess at least one of the specified conditions or all three?
Correct. One or multiple, right? So they can have one of those, they could have all three, but they have to have at least one of those three to qualify for that program.
Okay. And you mentioned Amber had also had the second portion of the presentation.
She did. I don't know if she's still having issues though.
Yeah, I tried to reach out. She hasn't answered. Amber, are you here? Okay.
I have her slides, but I'm afraid I will not do them justice.
Okay. Well, what we'll do is we'll take a short bio break.
Okay, perfect.
Give you a chance to maybe call her.
I will do that. Okay.
Okay. So
Appreciate
we'll take a short 5-minute break here.
Christy, do you want to
Everyone.
take 10 minutes? We'll come
Oh,
back at
10 minutes.
10:30.
Okay, that works. Okay, so we'll be right back in about 10:30.
Dexter, if you're still on with us, if you'd like to test your slides real quick, that now's a great time.
Yes, I will. Thank you. Okay.
Okay, I'm
Can you
seeing
see my slides?
yes, I'm seeing your slides.
Which one are you seeing?
I'm seeing your full home slide.
The Delaware
Delaware
Payer
Insurance
Workshop.
Payer Workshop. Yes.
Okay, let me
And they are advancing.
and same thing. Okay, so you're not seeing my notes or anything?
No.
Okay, great. Let me see if I can switch screens here, if it will allow me to change screens, because once again, let me get out, stop share, and try sharing on another screen. That's what happens when you have too much technology.
Understand, it's not always our best friend.
No, it is not. Let me share that screen and
Okay, I'm seeing your meeting planner.
yeah.
Your calendar.
Scale off it there. Put this over here. Okay, I think I'm gonna get it now here. Share this screen too. Share.
I'm seeing your main slide. I'm seeing your deck of slides on the left, and I'm seeing your notes at the bottom.
Oh, I just did what I'm not supposed to do. And which screen are you seeing right now? Oh, I stopped the share accidentally, sorry. Okay.
I'm
So which
seeing
screen are you
your
seeing?
full home slide. No other slides. I'm not seeing your notes. And your
Okay.
slides are advancing. I'm looking at your disclaimer.
Great. Okay, so we can work with that.
Okay, great. Perfect.
Okay. That will work.
Thank you so
whenever
much,
you are
Dexter.
ready, I am ready.
Okay. I think they're trying to reach a UnitedHealthcare rep for the end of their presentation. if you want to stop sharing your slides at this point, or I guess you could leave that up just in case we are moving on due to technical difficulties with UnitedHealthcare, but and that way you won't lose your slide.
Okay, yep.
Hey, Lynn, it's
Seems
Michelle.
like
I did get a hold of Amber. I'm hoping she's able to get this to work. We, for some reason, our systems do not like Zoom for some reason. It gives us a lot of grief. Yeah.
Gotcha.
So
Okay.
able to do this.
So is Amber on the line with us? Is she here?
She just said she is joining. It's spinning. So
I will stop share.
Okay. Thank you, Dexter.
Hey, Michelle, is it okay to share your contact information in the chat? Some folks may have additional questions.
Absolutely. Do you want me to put the email there, or do you guys have my email?
I have it ready. I
Okay.
just wanted to verify if that was okay.
Absolutely. Yep.
Okay, thank you.
Mm-hmm.
Think
Christy,
Amber's on. Yes.
this is Amber Frost. I'm sorry, I've been having technical issues trying to get into Zoom.
Great. Glad you were able to join us.
Okay, let's see.
Your audio is a little laggy. Let's see if you're able to share your presentation and hopefully it catches up.
Okay. Okay. It just said you cannot start.
Yeah, Lynn, Lynn, you have your
screen
screen
share while the other participant is sharing. Michelle, are you able to share?
There we go. Okay, it should work now.
Okay, let me try.
Okay.
One second.
Okay, so it looks like it's loading in.
Okay.
Okay, here we go.
Are you able to see that?
Yes, we can see your presentation.
Okay. You don't see my notes
No,
or
no,
anything
no.
like that, though, do you?
No.
Okay, just the screen. Okay, I just wanted to make sure.
Okay.
Okay. So, first,
Amber, your audio is really lagging.
first, I want to just go ahead and apologize again. I'm so sorry for the delay. Having some technical issues. My name is Amber Frost. I am one of the provider account managers with UnitedHealthcare. Is it? Can y'all hear me okay now?
Now it sounds fine.
Yeah.
Okay. Okay, so I think Michelle has already shared with y'all today. Is that correct?
Correct.
Okay. All right. So I'm going to go through mine. Okay, so I am going to discuss the UHC administrative guide as well as I'm also going to cover some of the provider portal resources that are out there and available to you through the provider portal, as well as our website. And I'm also an API. Let me just get through some of her slides because I had them in here too. I don't know why my computer is acting crazy through Zoom. Hold on one second. Okay. So first I want to go through the monthly and updates. So the 2026 UnitedHealthcare Admin Guide for Commercial Individual Exchange and Medicare Advantage view. For currently contracted care providers, just know that this guide is effective on April the 1st, 2026, which allows you 90 days to review the updates. And for providers contracted on or after January 1st, this guide is effective January 1st of 2026. And the newer changed information in these guides, it does include updates to communications and tools, discharge notification.
Hey Amber, I'm so sorry. We're really
expectations.
We're really
the same facility to facility transfers. It also clarifies existing.
Hey Amber, we cannot hear you. I think we're gonna.
Expectations.
Yeah, it's bad.
Radiology and cardiology requirements. Yes. It removed. Yes. Okay. I'm so sorry. I don't know why my audio's. Yes.
Amber, would you like to try calling in?
Yeah, I was just gonna
Okay.
make
I'm so sorry. I don't know what my audio's doing.
And also your slides don't seem to be matching as well. We're stuck.
Yeah, let me see if I can
Okay.
do that and I'll try to jump back on.
Okay.
Okay, thank you.
Christy and Lynn, do you guys want to go to the next presenter and we'll just try to see if we can figure out what in the world is going on and then we can circle back if needed. I apologize. It's our systems are giving us all kinds of grief today. So
yes, no, that's fine. We can go on to Dexter from CMS.
All right, thank you.
You're welcome. Dexter, are you ready? We can go ahead and do your presentation now, and then we'll move on to UnitedHealthcare after.
Thank you. Well, mentally I am ready. Let's see if Zoom is ready for me.
Okay.
So pull my slide deck up here and I will share. Okay, so I am up. Can you see my presentation? Or which one can you see?
Yes. So I see your presentation. It's not the full view. It's
not a full view. Okay.
Yeah.
Let's see if I can shrink this. What about now?
Now we see your desktop.
Now you see my desktop. Let's see if we can swap this out. Let me change desktop views. So I'm going to stop share and reshare my desktop. What about now?
Okay, now it's in presenter mode. So if you swap the display settings, if
So
you
you're
go,
still seeing my desktop view?
no, I don't see your desktop. We see your
You,
presentation, but it's the presenter's view. So if you go,
okay, got you,
yeah,
got you.
hit
Okay,
display settings and swap presenter, there you go.
got it now?
Yep, now we see it.
Okay, so what I need to do is move this over so I'm not looking away and speaking. And it doesn't want to move over. Come on. That's what happens when you have too many screens. So, for the sake of time, I'm just going to be a little bit rude, so to speak, and start a presentation so not to for the sake of time.
No problem.
Okay. So good morning, everyone. And everyone can hear me, correct?
Yes, we can hear you.
Okay, great. Thank you. Okay, well, good morning, everyone. First of all, apologies for the technical difficulties. That seems to be the familiar song this morning, but we will get through this. My name is Dexter Glasgow, and I am with CMS Region 3 here in Philadelphia, Pennsylvania, where I'm the outreach specialist for Region 3. So I'm delighted here to be part of your workshop, and we'll go over the topics of my presentation today. But first, I would like to say I have to give you the disclaimer, and that is pretty much saying that while this presentation is updated, that information here at the time of presentation is current, but as time moves forward, information may change. So please make sure that you take time, review the laws and guidance before you make an informed decision, because this presentation here, it's not a way for you to make an informed decision as it comes to running your organizations. It's just informational purposes and law can change. All right, so the topics we'll cover today, and here they are. It's about 8 or 10 topics. I'm not going to read them. Have you take a look at it, and then we'll go ahead and get into the meat of the presentation. Okay, so let's start with the Physician Fee Schedule 2026 final rule. So starting in 2026, Medicare will use 2 different conversion factors depending on whether a provider participates in a special type of payment model. Providers in APMs, and these are the doctors and practices in value-based models that focus on quality and on cost effectiveness. And this mostly pertains to the ACO, accountable care organizations, or bundled payment models. These participants are called qualifying APM participants, or QPs for short. Their conversion factor will go up 0.75% this year, 2026. And all other providers, those not in a qualifying value-based model, their conversion factor will increase by 0.25% in 2026. Now, this difference is required by law, and it's to reward providers who take on more responsibility for improving care and reducing costs. Also, in addition to the APM bonuses above, all providers will also get a temporary 2.5% increase in their payments in 2026. Again, this is required by law. There are some services who will see additional adjustments, about 0.49%, because Medicare is proposing to slightly raise how much work is assigned to them. Now, this is technical, but basically it means that certain services are recognized as more complex or effortful. Now, because of these changes, the base amount, that's the conversion factor, you will see increases from $32.35 in 2025 last year to $33.57 for providers in advanced APMs, which results in a 3.77% increase. And then others will see a $33.40 increase, and that's for providers that are not in the advanced APMs, which result in a 3.2% to 6 increase. Now, even though the base rate is the same starting point, the small difference reflects rewards for those who are taking part in new, more accountable care models. Now, here's where most of the big changes occur this year is the new efficiency adjustment. And the result of this is that for years, CMS has used survey data primarily from the AMA AMA Relative Value Scale Update, RUCs, and they use this to inform relative values for services in the Medicare physician fee schedule. Now, this includes work RVUs and practice expense inputs. But along the way, there's been concerns about the validity of this survey-based approach, which relies on low response subject surveys submitted by those with a financial stake in the results. So research suggests that this has resulted in a systemic overvaluation of procedural codes and underappreciation of time-intensive cognitive services like primary care. So what we did to address this is incorporate realistic gains in efficiency over time. So CMS is finalizing an efficiency adjustment to work RVUs and intra-service time for non-base services starting this year. Now, this is not going to be a one-time cut. This is going to reflect a new structural reform that aligns payment rates with evolving care, delivery patterns, and technologies. What this is going to also do is going to apply to non-time-based services that are expected to be more efficient over time, like the procedural and diagnostic codes. There are some exclusions to these services, and those are E&M, evaluation and management, maternity services, global codes, behavioral health, care management, and telehealth services. Now, this efficiency rate is going to be set at a -2.5 for calendar year 2026, and it's based on a 5-year average, the Medicare Economic Index Productivity Adjustment. Now, this MEI-based approach introduced a more objective actuarial method to calibrate adjustment and maybe revisit every 3 years. So pretty much what CMS is doing is signaling a shift away from survey data towards empirical time studies to better reflect the actual time and intensity required to perform services. This is going to be a major steps. Excuse me, this is going to be a major step towards correcting long-standing payment imbalances in Medicare. It also answers calls for MedPAC, Government Accountability Office, GAO, and health policy researchers to modernize the valuation processes and prioritize payment accuracy over legacy systems. I know that's a whole mouthful there, but this is just a synapse of how we're moving forward. Okay, looking at practice expense. So we're looking at the way we're going to update or how we're going to calculate practice expense values in this year for the physician's on the physician fee schedule final rule. We find this important because PE, practice expense, RVUs, or relative value units, they represent a major component of how clinicians are reimbursed under Medicare. So back in 2024, the AMA conducted updated physician free practice information and clinician practice information surveys, and then they submitted that data to CMS in early 2025. But after a thorough review, CMS decided not to use that data for the 2026 rate setting. Now, the concerns cited included small and underrepresented sample sizes, low response rates, incomplete submissions, and high potential for management error. The CMS did model the payment impacts of the new data and included it in the proposed rule to gather feedback. But due to the issues I just mentioned, they're going to hold off on the implementation for now. Now, when I say we, I'm referring to CMS, FYI. So CMS is going to be advancing efforts to integrate behavioral health into primary care. And we're going to do this not just by adding staff, but we're going to encourage true care coordination. We're going to have new add-on billing codes to support combining behavioral health integration or collaborative care model services with advanced primary care management, offering added payment for work many providers already do. Now, this integration is going to support team-based care. It's going to align with CMS broader goals for whole person health and reducing the administrative burden for providers. Excuse me. Clinical psychologists, social workers, peer specialists, and community health workers, they can now practice under they can practice more under fully guided supervision and get reimbursed. And CMS is also embracing digital mental health tools like the FDA-cleared devices for ADHD with expanded coverage and a request for feedback on broader digital reimbursement. Now, these changes echo the Make America Healthy Again initiative by promoting prevention, wellness, and smarter technology use. With over 60% of Americans managing at least one chronic condition, this policy aims to support high-need patients through more coordinated and accessible care. And also, CMS wants to reward providers already doing this kind of integrated care by making billing easier, supporting sustainability through value payment. Now, in skin substitutes, in this rule here, CMS addressed unsustainable spending trends for skin substitutes in Medicare Part B program. What we found is that between 2019 and 2024, spending on these products skyrocket from $252 million to over $10 billion, nearly 44 increase. And this is largely due to rising product prices and new high-cost market entrants. So to rein in these costs and create more consistency across settings, CMS is finalizing a new payment methodology. Beginning this year, skin substitutes will be paid as an incident to supplies rather than a separate Part B drugs or biologicals. This means that the payment for these products will be bundled into the application procedure when furnished in non-facility settings under the PFS or in hospital outpatient departments under the OPPS. CMS would align payments for groupings for skin substitutes based on their FDA regulatory classifications. And there's three, and those are the human cells, tissues, and cellular and tissue-based products, devices with pre-mark approvals, and devices with 510(k) clearance. For this year only, that's 2026, CMS is finalizing a single payment rate for all categories to avoid underpayment, and that rate will be $127.28. In the future years, CMS intends to propose differentiated payment rates by FDA product category to better reflect costs and clinical differences. And this new approach is not only reflects a more evidence-based, standardized, and site-neutral methodology, but also projected to generate substantial savings for the Medicare Trust Fund and promote competition among manufacturers. For the drugs and biological products on the Medicare Part B, we're going to start with the discarded drug refunds. So under the Infrastructure Investment and Jobs Act, manufacturers of certain single-dose containers or single-use packaged drugs are required to refund Medicare for specified discarded amounts. While two manufacturers submitted applications to adjust the percentage of applicable discarded amounts for 2026, CMS is finalizing no changes to those percentages at this time. Also, in the final rule, it makes several refinements related to the calculation of the ASP. The average price manufacturers receive for drugs, which Medicare uses as a basis for reimbursement. CMS is now going to define what constitutes a bundle arrangement and it's clarifying how bundled prices concessions should be factored into the ASP. This gives manufacturers clearer guidance on how to calculate ASP in situations where discounts are spread across multiple products. In addition, manufacturers must submit documentation of how they calculate fair market value for bona fide services fees. And these are fees paid to wholesalers, with purchasing organizations, and others for legitimate services such as warehousing or distribution, not disguised discounts. CMS is also requiring that these services not be passed on to customers to preserve the integrity of the ASP calculations. However, CMS did not finalize a revised definition of the BFSF or specific valuation standards. And then most importantly, CMS is confirming that units sold at the Inflation Reduction Act maximum fair price will be included in ASP calculations, and that began January this year. And this is going to ensure that price reductions negotiated under the Medicare Drug Price Negotiation Program are fully reflected in Medicare Part B reimbursement amounts. What CMS is going to also do, we're going to expand the existing bundle payment policy for CAR T therapies to now cover all autologous cell-based immunotherapies and gene therapies. And what this means is that the preparatory services like cell collection needed to manufacture these therapies will be included in the drug payments amount. CMS will allow manufacturers to treat payments for those services bona fide service fees, provided that they meet the regulatory tests. And these fees will remain excluded from ASP. So putting this all together, is that these changes is aimed to strengthen price transparency, ensure consistency in the ASP calculations, and appropriately pay for cutting-edge therapies, all while safeguarding the Medicare Trust Fund and ensuring that beneficiaries have access to needed treatments. All right, let's switch gears and go over to our QPP, Quality Payment Program. So for the 2026 updates on MIPS value pathways. As you most of you well aware that MVPs represent CMS long-term strategy for modernizing MIPS. They aim to make reporting more relevant, meaningful, and specific and specialty specific for clinicians by bundling together measures across quality costs, improvement activities, and interoperability categories. And this approach is designed to reduce clinician burden and improve the alignment of performance measures with actual patient care. So for 2026, CMS finalized 6 new MVPs, bringing the total to 27 MVPs available for reporting. And the 6 are diagnostic radiology, interventional radiology, neuropsychology, pathology, podiatry, and vascular surgery. These additions further extend MVP participation opportunities across diverse specialties that had previously lacked tailored options. All 21 previously finalized MVPs were modified to align with updates in quality and improvement activity inventories. CMS also finalized a policy requiring groups to self-attest their specialty composition, whether they are a single specialty or a multi-specialty group during the MVP registration process. This approach gives groups autonomy, while helping CMS track participation trends more accurately. And importantly is that the multi-specialty small practice, they can still report MVPs as a full group. Subgroup reporting remains optional for these practices as well. Now, concerning the qualified clinical data registries and qualified registries, they will have a 1-year delay before they are required to support newly finalized MVPs. And this implementation buffer allows time for necessary system updates and smooth onboarding of the new pathways. And putting this all together, these updates reflect CMS' effort to gradually shift away from traditional MIPS and toward a more structured, clinical, meaningful MVP framework while giving stakeholders time to adjust and prepare. Continue along the MIPS performance categories and threshold. As we look at the performance categories and scoring, CMS proposed to maintain the MIPS performance threshold at 75 points through the 2028 performance period, and this affects payments in 2030. This provides clinicians with predictability and help them plan their performance improvement strategies. Under the quality category, CMS alignment with the APM Performance Pathway Plus with a larger MIPS quality inventory. This supports consistency across participation tracks. For the cost category, CMS is refining attribution rules for the total per capita cost measure. Importantly, new cost measures will have a 2-year feedback-only period. What this means is that clinicians can see their scores and make adjustments without these scores affecting their final payment adjustment. The improvement activities category sees some significant shifts. Here, CMS proposes 3 new activities, 7 revisions, and 8 removals. A new subcategory, Advancing Health and Wellness, is being added, while the previous Achieving Health Equity subcategory will be removed. And finally, under promoting interoperability, CMS is refining existing measures like the SAFER Guide and proposing a new bonus measure tied to DEFC8, the Federal Health Data Exchange Framework. Additionally, CMS plans to suppress scoring for electronic case reporting in 2025 due to CDC's temporary pause on onboarding. Advanced APMs. So CMS can finalize a more flexible approach to quality APM participant determinations. At the moment, QP status is defined at the APM entity level. The final rule adds individual level determinations as well. This change is designed to reduce complexity and ensure more eligible clinicians get recognized for their APM participation. It would use covered professional service as the basis for that determination. Moving on to Medicare Shared Savings Program. So taking a look at this and putting it in perspective, we're talking about changes that will affect nearly 500,000 providers and over 11 million Medicare patients, which is roughly about 20% of all Medicare beneficiaries. The Trump administration goal with these policies is clear. Move ACOs towards shared risk arrangements more quickly to drive better chronic disease management, more efficient resource use, and increased savings for the Medicare Trust Fund. Changes in shared savings program participation options under the basic track are applicable for agreed periods on or after December 1st, 2027. The 12-month implementation timeline gives us time to plan, but these changes represent a significant shift in how the program operates. For those of you who are currently in one-sided risk arrangements, this is important to understand. Participation database in the Shared Savings Program Fast Tracks as of January 1st, 2025. I highly recommend you to check the Shared Savings Program website in 2026 for updated information. And this can just be found on the cms.gov Medicare Payment Fee-for-Service Shared Savings Program site. Continuing along with Shared Savings Program, as it relates to encouraging risk and improvement policies, program policies, CMS is going to shorten how long an ACO can stay in a one-sided risk model. So for agreement periods beginning on or after January 1st, 2027, ACOs will only be able to participate in a one-sided risk for 5 years, which is a decrease as it used to be seven years. This change is intended to accelerate a transition towards taking on more financial responsibility, just like in the basic track level E or the enhanced track. For agreement periods beginning on or after January 1st, 2027, Siemens is going to add flexibility to the 5,000 beneficiary requirement. ACOs now only have to meet that threshold in benchmark year 3 to enter the program, even if they fall below it in years 1 or 2. But if they do fall short, they will be limited to participating in the basic track and are prohibited from participating in the enhanced track. More generally, for agreement periods beginning on or after January 1st, 2027, an ACO with fewer than 5,000 assigned beneficiaries in any benchmark year may face alternative caps on shared savings or losses, and exclusion from policies providing low revenue ACOs in the basic track increase opportunities to share in savings. Continuing here for transparency and accountability, ACOs will be required to report certain ownership changes in real time, not just annually. Now, this is going to include the TINs and skilled nursing facility affiliates that go through a change of ownership during the year. CMS is going to also update how it defines primary care services for purposes of beneficiary assignment. We now include a new creative behavioral health integration and psychiatric collaborative care management add-on services, alongside keeping G0136, the physical activity and nutrition screening code, as that remains payable under the PFS physician fee schedule. Now we're going to rename the health equity benchmark adjustment to population adjustment. And we find that this better reflects the population served by the ACOs receiving the adjustment. Beneficiaries who are enrolled in the Medicare Part D, LIS, or dual eligible for Medicare and Medicaid. We've also finalized remove the health equity adjustment applied to an ACO quality score beginning this year, and finalized remove the terminology used to describe the health equity adjustment and other related terms in the shared savings programs. And this is to reflect the data used to calculate the health equity adjustment for performance years 2023 through 2025. Good thing to know is starting in 2027, the CAHPS for MIPS survey will be collected through a web mail phone approach instead of just mail and phone. And this should help boost response rates and better capture patient experience. Reducing burden and protecting ACO performance. So to ease the reporting burden, we've got a lot of comments on this. CMS is going to change who comes as a Medicare CQM eligible beneficiary. As in back in 2025, a person must have at least one primary care visit during the year with a qualifying provider. And this better aligns the reporting population with actual ACO assigned patients. We found that ACOs hit by cyber attacks like ransomware, they can now qualify for extreme and uncontrollable circumstance relief. If CMS grants an exception, the ACO wouldn't be penalized for performance issues in the affected year. And then starting this year, ACOs will be evaluated against both the regular quantity standard and an alternative standard. If they fail to meet either, CMS can now take corrective actions up to and including termination. So taken all together, these changes are about encouraging risk taking, simplifying quality reporting, and protecting both ACO and the Medicare trust funds through better defined rules and safeguards. Okay, quick overview here of the ambulatory specialty model. So this is a new CMS Innovation Center initiative, and it targets specialty care for two conditions with high Medicare spending, and that's the low back pain and heart failure. Those are the two conditions. So this model will begin in 2027, and it will assess 5 years of performance with payment adjustments beginning in 2029. It's focused on empowering specialists to take more proactive roles in managing chronic disease. Participation is limited to certain specialists who meet volume and geographic criteria. The goal here is to shift specialty care toward value-based principles, prevent unnecessary interventions, and drive better health outcomes through enhanced collaboration. So ASM participants include both surgical and non-surgical specialists who frequently manage low back pain or heart failure. CMS will evaluate those performance across quality, cost, care improvement, and data sharing capabilities. And this will include both clinical benchmarks and infrastructure investments, like interoperable electronic health records and collaborative arrangements with PCPs. And these measures will reflect the growing recognition that specialists play a vital role in managing chronic conditions, and that coordinated whole person care leads to better outcomes and fewer unnecessary services. For the payment adjustment and care transformation, ASM will introduce significant financial accountability for specialists. So beginning in 2029, Medicare Part B payments will be adjusted based on performance with bonuses or penalties up to 9%. Now, this model is budget neutral, so participants are collectively responsible for driving results. To succeed, the nations must build stronger ties with primary care, engage patients in goal setting, and screen for social determinants. And CMS will supply performance data and support care transformational efforts. Here you have on the slide just shows the information timeline. I'm not going to go over that much, not much to add there. Just know that organizations should determine that if they may be affected, they need to begin preparing for potential inclusions and keep an eye on future updates and support from CMS. This is a major move towards value-based specialty care, and early preparation will help you ensure a smoother transition. And as you can tell, this model will launch January 1st next year. And that brings an end to my presentation. I appreciate if you take a quick capture that QR code, provide any feedback. It's all appreciated. Thank you so much. And here's my contact information. If you need to take a picture of that, you have any questions, you can reach out directly to me, or maybe you can reach out through Kristen or Lynn. And finally, any questions?
Thank you so much for your great presentation. A lot of good information there. Does anybody have any questions for Dexter? Okay, could you put the contact information back up?
Sure can.
And a question did come in while you're getting that. Do we have any update regarding extending telemed after January 31st, 2026?
I'm sorry, could you please repeat that?
Yes. Do we have any update regarding the extending of telemedicine after January 31st, 2026?
I'm sorry, nothing has yet on that. We'll keep an eye on that because we do have a lot of providers that are very interested in those changes. We're keeping an eye on it. As soon as they let me know, as you know, I will send it out to you, Kristen, so you can share with your partners.
Okay, great. Thank you so much.
And is my contact information being displayed?
Yes, it is. It's in small, but it's
Oh, it's
there.
small. Okay.
Yeah.
I'm sorry about that.
You would just have to swap display settings.
Yeah, yep, that's what I'm about to do now. Oh, screen share stop. I tell you what, I will just drop it in the chat so everybody
Okay,
can have it.
that
Okay?
works. Yep,
Okay. Sorry about that.
no problem. Okay, I don't think we have any other questions. So again, Dexter, thank you so much for the information that you shared with us. We truly appreciate it.
Thank you for having me. Thank you so much. I appreciate it. Well, glad I can.
Thank you. Is Amber, are you there? Michelle?
Yes, I'm here. Let me see if I can share my screen, and hopefully we can get this through here. Let's see.
Okay.
Okay, are you able to see my screen?
It's loading in. It hasn't pulled in yet. Here we go. So we see the 2026 Administrative Guide.
You got it?
Yes.
Okay, perfect. So I was going through that when are y'all able to hear me now? I know we were having audio issues earlier.
We still seem to be having audio issues.
Can you hear me?
We can hear you, but
Oh goodness.
it's very delayed.
Okay.
Could you perhaps call in on the Zoom meeting?
I've already
Christy, I think you tried to call in and there was like an echo.
Oh, there was.
Yeah. Is there any
this
way
is
to just maybe pick
me
up in another
calling
meeting?
in.
Is that possible, Christy? Could we just try to jump?
So I'm not really certain what the audio is.
The echo normally comes from not muting your computer. If you don't mute your computer.
I mean, and this information, I can. Let me see. Hold on one second.
If you call in and you
Okay, can you hear me now?
Yes.
Can you hear me now?
Yes, I can hear you.
Okay, yeah, I don't think that's working. I tried muting.
No, that sounds
my
much
computer.
better.
What I can do, I hate that we're having audio issues.
No, you're breaking up again.
You can hear me okay?
No, you're still delayed. I'm sorry. Christy, I'll give the floor back.
Okay. Well, let me see what I'm not sure what happened. Okay. So I think I went through the slide, so let me move on, and please tell me if y'all have trouble hearing me. Now, what I can do, I mean, I can share my slides with y'all if I don't know if that's at all possible. If it is, I can provide y'all with that information. Can you hear me?
Yeah, Lynn, I'm wondering if we can share.
Are you able to hear me when I don't share?
Yeah, I think, Amber, thank you so much for trying again. And thanks for everyone in our group for hanging on with us. Amber, we're not hearing your presentation, but you're still breaking up badly. So if we could share your slides,
Okay.
if you have your permission to do that, we'll just go ahead and share your slides with everyone and ask them to reach out with any questions. We understand technology sometimes is just not cooperative.
Okay, this is Michelle. We'll make sure to get it over to you guys. Or if you just want to, I think Amber sent it. If she didn't, we'll get it over and it can be shared with the group. Apologize again for the technical issues here. So.
Yes, no problem. Yes, if you could just send that my way, and I'll go ahead to make sure that we share it with everybody who attended today's session.
Perfect. Okay, thank you.
I believe I did share I did share your contact information if anybody did have any questions directly for you. Again, thank you so much for at least attempting. Thank you so much. We really appreciate it.
Apologize. Yeah.
Well, okay, that concludes today's session. This presentation has been recorded and we will provide this on our YouTube channel. And again, I will be sharing the link for that as well once I share the slides. Thank you again, everybody, for today and a great session.
I want to thank everyone as well. We truly appreciate your participation and thank you to all of our great speakers today from the insurance payers. And we will get that information out to everyone. Christy, when she sends you the information, she'll also send you a survey for all of our participants today. If you could please take a minute to, it's a really brief survey. If you could complete that and get it back to us. It's very, very helpful, not only with today's presentation, but to help us plan for future education. So we want to make sure we're getting you the education that you want and need. So we appreciate that. Thank you.
Yes. Thank you so much. You guys have a great day.
Have a great day.